Hello, I'm Pati Papineau and welcome to my show. My guest on today's show is Matt Saltis from the Vermont Center of Independent Living, and we're going to learn all the wonderful and valuable work they do for disabled people here in the state of Vermont. Welcome, Matt. Thank you for coming down from Montpelier.
Thank you.
We should say that you are the Education Director, Manager for the Central Office, which is located in Montpelier,
Right.
for the Vermont Center for Independent Living.
Mm-hmm.
Now, for all of our viewers who are saying, what is that?
Mm-hmm.
Explain it to us.
Yes, well, we do get a lot of calls from people who say, I need an apartment, things like that.
More independent, like living alone and being away from
Right.
the nest, as opposed to what you do.
Right. Basically, we serve people with disabilities anywhere in the state of Vermont. And people come to us with all sorts of different issues, but our main goal is to help people live independently and all that entails. So it's housing, employment, whatever issues someone wants to work on is what we work with them on.
Now,
So-
how long has the center been in existence?
I think it's around 20 years.
That long?
I think so, yeah.
You are a nonprofit organization, we should
Right.
say, and you are funded by local municipalities, the United Way, and various grants.
Sure. Yeah, a whole big combination.
And it all puts
Yeah.
together to make a wonderful pot pie. How many people in the office? We have 3 offices, but let's talk about the central office in Montpelier right now.
Right. I'd say there are about 20 people down there. It's a center of operations in a lot of ways. We run a strong advocacy program. We have a presence in the legislature, so there are a lot of people who support that effort. But I wouldn't say that dominates the office down there. We have a lot of people who work in the field who use Montpelier as their home office for the surrounding areas. There are people who are constantly putting together public relations type of things. There's the center of all the programs with home access, with our information referral department is out of Montpelier.
Well, we want to go slow a minute,
Sure.
because you're going real fast, and probably the people are not quite understanding all the specifics and what's involved. First of all, let's define disabilities, and what kind of disabilities qualify for people to get assistance. And we don't mean monetary assistance. We're talking about counseling and legal and all kinds of various things. You really cover a whole umbrella. But
Right.
what kind of disabilities qualify?
Well, you can use this fairly broad definition. We usually don't grill people as to how serious it is or anything like that.
They don't have to provide a doctor report.
Right.
They do not have to provide proof of SSI or any kind of a disability.
No, we don't ask for
Any
like
criteria at all.
No, we just go on people who come to us and request help based on whatever they're dealing with at the time, and so generally people have a good understanding of their own situation, of when they need assistance, or at least just somebody to talk to. It's usually where it starts, and from there, it can be anything. One thing about disabilities that we're trying to help people understand is that under the Americans with Disabilities Act, or the ADA as it's known, many people qualify for protection under that act based on many different disabilities.
Right.
And one thing people usually don't put in there is psychiatric disabilities, or mental illness is also another name for that. So, and also we're perceived as focusing mostly on people with physical or maybe cognitive disabilities, but mostly physical disabilities. So we want to make it
Recognizable
clear.
disabilities.
Yeah,
Right.
the more visible, the more obvious, what people would think of when you think of disability. But there's certainly many different hidden disabilities that people have to deal with. Do I tell people about it? Do I, if you have a vision impairment you're not actually legally blind, do you carry a white cane or not? People make this choice all the time because it helps other people understand what's going on. Some people wouldn't carry a white cane. Others will because it makes life easier. So people come from all different angles with it and how they cope with it. And our mission has always been to listen to our peers with disabilities and listen to what they want and need. And we're not going to case manage somebody. It's going to be a matter of really helping someone self-advocate and, you know, when they ask us to advocate for them.
Over the 20-year period that the center has been open and available to Vermonters, how many Vermonters has the center worked with?
I wish I knew that. I'm sure it's in the tens of thousands or more.
And how many would you say in the past year?
Well, I do know that if you count all of the information calls...
Sure, everything.
Yeah.
You know, from a small amount of help to a large amount of assistance.
Sure. I know that we got about 4,000 calls last year. So that's a good chunk. And that often leads to other things, such as a referral to our peer advocate counselors.
Sure.
Or some other referral, or people can come in and use the library. So there may be all sorts of interactions that don't get counted, but we're a pretty busy place.
Let's right now, right off the bat, say that you do have a toll-free 800 number at the central office in Montpelier.
Right.
It is?
It's 1-800-639-1522. I give it out all the time.
All the time.
Yeah.
And also that there are 2 other offices in the state.
Right, we've covered the South pretty well with Bennington and Brattleboro.
Right.
The good news is, for people in the Northwest, is that we're weighing our options in the Burlington area. We'd love to get an office up there. I commute from Burlington, and I'd love to work closer to home. But the main thing is there are certainly lots of people up there. It's hard for a lot of people to get down to Montpelier. So that would really help us out in both outreach and you know, being visible, but also certainly reaching the people in all those areas.
Well, of course, you do have field service offices in every county and in municipalities in the state. And we'll talk about that a little later on the program because we have a special guest later on. We also want to say that we want to give the Bennington phone number and the Brattleboro phone number of those 2 offices.
Sure. I'm not so familiar with
Okay. Well, Bennington would be, of course, 802 area code 447-0574. And the Brattleboro office is, again, 802 area code 254-6851. How did you become involved in the center, Matt?
Well, I joined them late last year. I just saw it on the paper, and it was about their information referral department. So for a while I worked on the hotline, or we call it the warm line, because it's not really geared towards crisis calls, but we certainly get plenty of sticky situations, people looking for help, or certainly just an avenue to pursue. But I'm trained in social work. I had a master's in social work from UVM, and I was working in domestic violence prevention for a long time. But that became a little too hectic for me. It's a very difficult field, and so myself and members of my family had been dealing with some chronic disabilities for a while. And what I had trouble with really was just adjusting to the onset of something that was limiting me. I had a back injury, and that's another one of those invisible things too. And so to everyone else you appear to be a healthy young
normal
man, but you don't want to lift things or whatever. So it exposed me to a lot of the difficulties, and also my sister was dealing with a very disabling condition where she was losing function in any part of her body that she used for more than a few minutes. It's called reflex sympathetic dystrophy syndrome, where the nerves fire a pain response. This is a very long answer to your question, but eventually any part of the body that you use becomes very painful, and the recovery period is very slow. And she had just a terrible time trying to get a personal assistant in her home, trying to get support for her educational needs, because her voice eventually was unusable because it would cause so much pain. And her hands were so painful that she could use them very little as well. So she needed help with note-taking and other transcribing. And just the whole combination of needs and just a very difficult situation. And it really it moved me to want to get involved, to just be that person who could at least... The ad was about giving out answers, referrals, ideas. And I figured I could do that. At least when they get someone on the phone, it's someone who's actually going to try to work with them. Because we would get a lot of people on the phone who'd say, "I've called everywhere. I'm getting the run. I feel like I'm getting the runaround," and sometimes, they genuinely do. And so we're trying to be the place where people can actually get an answer out of somebody.
And so you do a whole variety of things, from legal advice, steering people, to living independently, to counseling, to information on local citizens or local agencies that might be able to specifically help them. Accessibilities and helping all of that way. So it's a wonderful function. Who is the director of the Vermont Center of Independent Living?
Our director currently is a woman named Anne Marie Morano, who joined us a couple of years ago, answering the phones, and really found her place there. Unfortunately, she is leaving us at the end of the month. So we're going to have to search for a new director, which is really too bad. I like the feel of the office down there. It's very, people really help each other out within the office, and it's a good spirit down there.
So do you have like a governed by a board of directors or that sort of thing?
Sure. Yeah. And so they're jumping right on it. They're very actively looking at ways that staff can have input into the choice and the style of the director too.
I think something that's very important here is the fact that everyone at your offices is disabled. So that when a person who is disabled, either temporarily or permanently, when they call, they're not getting somebody who's never walked in those shoes and doesn't really understand, either through firsthand or through a family member, but hasn't been there and understand what it's about. And I certainly don't want any letters and cause any problems, but sometimes when you're dealing with people with welfare or SRS here, in the state it's called SRS, or caseworkers, they don't always understand what it's like to be hungry or what it's like to have be homeless. But when you have people actually working, answering the phones on a warm line or in an office who are living it and have been through it, it can make all the difference in the world. I mean, understanding and knowledge and sympathy and caring. And if you've been through those ropes, life is easier when you can help somebody else. And these are, again, we want to say, very important that this is a nonprofit organization. This is an 800 phone line, and the 3 offices that you have established in the state are there to call for free information and help in every possible way for disabilities, even disability access into or getting a job and employment and things like that.
Yeah, and all of the services generally that we offer are also free.
Well, what are some of those services?
Well, there's a whole combination of different things. We do this sort of everything generally starts with the information and referral line, or I&R.
Well, you have to know what somebody needs.
Right. So we'll talk to them for a few minutes and try to figure out what's going on, or sometimes we talk to them for an hour. The in-house programs, there are a few funding programs for essential equipment. So stuff like there's one program for assistive technology, and broadly speaking, that's any sort of device that enables you to gain access to the media, the people around you, anything that helps you just with your activities of daily living is another cliche term. So hearing aids would count. A wheelchair is assistive technology. If you have trouble grasping things, a grasping wand or whatever it might be, certainly a seeing eye dog would count.
Sure, absolutely.
Computers to monitor someone's blood sugar level, all these things we can help people with.
We want to stop right here, and
Sure.
I want to say to everybody, this is Matt Saltis from the Montpelier office of Vermont Center for Independent Living. But for anyone that needs anything like this, you do have a catalog and have access to these kinds of things. For people who may have difficulty finding or locating such things, they can also call. So you have educational programs, and you do have these tools and things available, along with helping people with their legal and civil rights.
Yeah, we constantly try to be more full service as possible. We're always passing around different resources, especially funding sources or support services. as we know about them, we pass them along to the people that work the phones and such.
Well, they're really, when you call, and I love the name Warm Line instead of a hotline. It's really slick. But, I mean, they have to really be the most knowledgeable because they're the first contact anybody has with your office in the agency.
When I started there, I was always going to the medical dictionary and looking up various syndromes and because people, they toss a term at you and then they go on and they assume you know what it means because we are the state agency working for people with disabilities. So, that was a tough job to prepare for because you never knew what's going to come in, right?
And certainly the agency we know for a fact works with between at least 3,000 to 4,000 peers a week. And you don't call them clients, and tell our guests about that.
Yeah, clients assumes a sort of hierarchical relationship where one person is being served and the other is the server, the knower of all. So we try to, well, certainly our whole approach is very strongly and intentionally directed to be very peer-centered, as we say. So these people are not our clients; they're not our consumers of our services. That we have something to offer. We try to perceive it as working with our peers in the community, someone who is our equal, someone who has lots of good ideas of their own and understands their own strengths and weaknesses.
Do you work just with adults or children also with disabilities?
We work with children also, but mostly with adults. There's certainly lots of resources for children, and like the Parent-Child Center and the Parent Information Center. There are lots of different places that people think of for kids. So sometimes we get calls from those, some caseworkers there, or some parents, depending on how well their needs are being met. But mostly we work with adults.
I just want to backtrack a little bit on disabilities. That oftentimes, in your case, you had a disability which is temporary. Sometimes people are just getting over an accident or a problem. And then sometimes disabilities are they're born with or long-term. But you handle, the point is that you work with all people. Right.
I think the definition really focuses in on its effect on your life. If
it inhibits a day-to-day normal, quote-unquote normal.
Employment.
Or normal living.
Or I think is brought as enjoyment of life.
That's true.
Sure. That's something that, that the ADA is a wonderful tool to reinforce the idea that everyone deserves access, as full access as possible. And we have a lot of tools to make that possible. And in a rural state, often we're chasing around some of these smaller towns to really open up their libraries or central areas, shopping areas, even some of the service organizations are difficult to access with various disabilities. So,
well, wouldn't you say that the advent and the passing of the ADA, the American Disabilities Act, was really the forerunner in fronting of having ramps into public access buildings and into hospitals and into libraries and schools and things like that, and even into restaurants, handicap accessible, as they call it.
Yeah, I think, well, it really kicked it into high gear, and it also turned it from more of a, that's really nice if they put a ramp there. It turned it from sort of a convenience to a civil rights issue, which it completely is. I mean, it's absolutely has to do with the individual's right to access their community.
Absolutely.
But it was often seen as something that was
an extra,
as a favor. Right.
Let's talk a little bit about your resource center and library that is available to people.
Yeah, that's in Montpelier, so you have to make the trip down there. But
well, you say down there. It depends where we live in Vermont.
That's true. Actually, you don't. I should take that back because we will work with you on the phone and send you whatever you need. We do that quite often, and you can keep things for 2 to 3 weeks. We have a large number of videos that can be used for training or educational purposes. There's a lot on sign language and communication for the deaf. There's a lot of research materials for all sorts of disabilities. There are biographies, and we even have John Callahan's cartoon books down there.
Tell us about your educational programs that you offer.
Well, education is sort of arranged when people make requests. I, as an education manager will make some trips out to different groups, or
like a
maybe
civic organization or
Yeah.
a group to speak.
Yeah, often
publicly.
people will call us up, and we get plenty of requests as it is for someone to come down, and we got a call from the cerebral palsy group in the Bennington area. So our peer advocate counselor from Bennington showed up and just talked for about half an hour, and he said he was amazed that some people had never heard of us, even though there were a lot of things that we focus on that people really wanted to talk about, wanted to meet with somebody about.
Well, now that we have the show, maybe people will be more aware that you exist and the wonderful work you do. That's so
Sure.
important. I know that a lot has been done over the last 20 years and a lot in the last few years with the American Disabilities Act being passed and laws now required for handicapped and disabled. What else would you like to see done in the future?
Okay, well, I've got a little list of the things we're working on.
Okay.
So-
I was going to say, that's a separate question. What you, as an individual who now is working in that office for some time, worked the hotline, now to the education manager, what do you personally feel still needs to be done in this field here in the state of Vermont?
Well, I think a lot of it comes down to access. I mean, in a rural area, access is a problem, especially with the weather. Physical access, as well as for sensory disabilities like deaf and hard of hearing people, we're pushing to have TTY phones, teletype phones at rest areas. That's also a safety issue. But I would say the number one issue that we face right now would be transportation.
In what way?
Well, it's with a very poor intercity bus system, and also transportation is very scattered here. There are long distances to travel.
Oh, yeah.
It can
Very
be-
rural.
It can be difficult. I mean, it's just it would be hard to make it any tougher to provide a really universal transportation system. So that's how I see it, and to really get transportation into all the small little areas, and a lot of that has to come down from mandates or government, or we really need a transportation broker here, because and we do have people covering all the areas, but they can't do a whole lot beyond the usual sort of daytime and Saturday hours, and so it's tough. I think that's a big challenge to Vermont, especially with all these light rail ideas and different ideas with this and that. And Greyhound for interstate is fighting mandates to put lifts in their buses, and it's a very tough thing. And it comes down to dollars and cents a lot more than it comes down to thinking of individual Vermonters without cars and without transportation, who have little choice but to live by themselves and not really fully enjoy their community. So,
Or vice versa, live in an institution when they perhaps could be out living a more independent life. Both sides of that coin.
Yeah.
I know the Vermont Center of Independent Living has two advocacy teams. Tell our viewers about both of them.
Well, there's the Peer Advocacy Counseling Program, and that's where we have representatives covering the whole state. So this is where someone can actually meet you face to face, usually at your home, or you can pick a place that's mutually convenient. But that's a real person who can really sit down and talk to you and listen to what you are working on and work with you for up to a year or so. I once asked what's a typical length of time for someone to work with a peer advocate, and they said, well, 3 to 4 months is typical. A year is also typical.
Individual cases are individual.
So some people want a lot of work on self-advocacy and maybe some self-esteem. Other people, they just want a job. They've got skills, they have confidence, they just don't, they're frustrated. Other people are trying to get used to a new injury, or they're dealing with a secondary condition, such as depression, as a result of the disability they're already dealing with. So it could be anything, and these folks are very resourceful, they're very creative, and they're not scared to deal with just about anything. So I think they're one of the best things we do, is that we offer, is someone who can really come down and listen and talk and just help you sort it out.
and understand it and been there. We do have tonight, as also one of our guests, one of these peer advocacy counselors. Very glad that he was able to join us tonight with you from the Vermont Center of Independent Living. We did talk about earlier that there are various field offices around the state, and we have with us someone from the Brandon area tonight to join us on our show and talk a little bit about exactly what he does and what he functions, and basically he handles Rutland County. And I welcome to you Hector Racine.
Thank you.
Thank you. Hector, how long have you been involved with the center?
I've been involved with the center for 11 years.
11 years, that's a long time. I'm sure you've seen a lot of cases and helped a lot of people.
Yeah, I was on the board for 2-year terms, 2 or 3-year terms, and I've been a peer advocate counselor for 5 years.
So let's say that we know you're based in the Brandon area. You go around, basically it's Rutland County is your area because there's not a specific office there. There's a central office we've talked about in Montpelier, and then there's the offices in Brattleboro and Bennington, but Rutland County really isn't covered, which is a shame because Rutland is our second largest city. And even here in Middlebury, it's a very large population here in Middlebury and Addison County. So in Burlington, we really need to get this developed in more parts of the state. But tell us a little bit about what an average day might be for you. You get phone calls. People can reach you, we should say this, by calling the 800 number in Montpelier.
Yes.
From Rutland County. And then they can reach you and tell us about an average day.
On an average day, I go out and see 2 peers. Well, you know, I'll get the referral. It comes to me.
And then from the referral to when you actually get to somebody's home to meet with them personally, how long might we be talking? A couple of days, couple of weeks?
We have a waiting list
You do?
sometimes. It depends if you're working part-time or full-time. And I work part-time right now, and I work with about 22 people a month.
A month.
And through that, you know, you've got I average on 2 peers you try to go out and see at certain intervals. You try to level your workout. 50% is on the road, 50% is at home where you're home-based.
Telephone.
Telephone, communication. So yeah, on an average day, I go out and work with my peer. I'll call them up and beforehand set an appointment. I'll go out and see them, and as we meet for the first time, we'll go over a needs assessment sheet that we have, and it will list all the goals that they're looking at. You know, it could be on accessibility, it could be on civil rights, it could be on Medicaid, it could be on Social Security,
employment,
it could be on social recreation, could be on active daily living.
I'm going to say yes, maybe assistance in the home.
Yes. And that's where, you know, and that's where mine is right now is, so we have a really variety, and working by phone is really effective too.
So you meet with someone, and that might take anywhere from an hour to maybe 3 hours?
It all depends on the person.
On the person and the needs involved.
Yes.
Of all the people that you work with, and you've been doing this for so many years, what would you say is the primary concern across the board, if there is one?
What I've seen across the board would be long-term care.
Long-term care. In-home long-term care? Outside of an institution?
That's correct.
Right.
Yeah, and then I work with my peers under Medicaid and getting assistance through home health, Medicaid waiver, and under Medicaid waiver, you get homemaker service, and you're allotted so many hours per day.
So let me ask you this. Let's take an example of case A, and somebody calls you, and you meet with someone. And you go to their home and you talk with them, and they need home care and a homemaker and maybe a physical therapist or X, Y, and Z at home, Meals on Wheels or something. You give them the tools to call up and make those contacts and those arrangements, or do you actually do those things for that person?
What we do is we sit down and do an independent living plan.
Okay, of what they're capable of doing.
That's what their goals are.
Mm-hmm.
So, for example, if they just came home and they needed assistance, we would look, okay, you're home, do you need accessibility? Do you need health care?
Mm-hmm.
Are you in a chair?
Right.
You know, what do you really need?
Mm-hmm.
And then after we set them goals, we work together.
Mm-hmm. Together.
We don't do four.
Mm-hmm.
We work together.
Right.
So that we give them skills training. So a person may need to use the phone
Mm-hmm.
to make a call to a service provider.
Mm-hmm.
And they may be very shy of the phone. So
Mhm.
you've got to prep them up
Teach
before
them.
you get to the phone
Right.
for them to make the call.
Mhm.
And you also advocate for them.
Mm-hmm.
If there's something that we cannot find right offhand, we'll do research. We'll call the Center for Independent Living, the library.
Mm-hmm. That's where our Matt comes in and people in the central office in Montpelier.
Yes.
Mhm.
Sometimes.
And we also, we refer people. You know, we refer them to home health, service providers, agencies such as Brock,
Mm-hmm.
the Community Action Resource Team,
Mm-hmm.
Social Security Administration, Department of Social Welfare.
Mm-hmm. Where does the United Way fit into this?
United Way, their funding comes in to the center and it's distributed into different parts of the programs where we have some access to it.
Mm-hmm.
Part B, which is the Independent Living Resource.
Mm-hmm.
Resource, if a person needs assistance with, and they have no funds, it needs like Meals on Wheels,
Mm-hmm.
for a person to come in and give them Meals on Wheels,
Mm-hmm.
we would call Part B,
Mm-hmm.
Information Living Referral,
Mhm.
Resource, and talk with them, and we would try to get them their meals. We would also, we would work with getting them any durable medical equipment that Medicaid or Medicare wouldn't cover.
I see. Mm-hmm. Very important.
Yes.
That they need but won't be covered, right?
Right. And it's a very interesting situation with every person is different.
Mm-hmm. Certainly, each case is so different and unique. Also, we might add here that I would certainly assume that there's confidentiality is a very important key to your office and to your work, so that each case is kept quiet and protected and confidential unto itself.
Mm-hmm. Absolutely.
Yes, absolutely.
And each individual circumstance is different and therefore confidential.
Yeah, and that's true even within the office.
Uh-huh.
We don't tell stories within the office either.
I would hope not.
Yeah.
It's not very professional.
Well, I've been in certain places where
Oh, I have too, but
it's assumed that amongst yourselves you can talk about anything that's going on, but you just don't take it outside the agency. But even that we feel it's just too gossipy in a small state where you're really trying to, you're not trying to get in and help someone manage their life. You're really helping. You're just listening to them and asking. Doing what they ask you to do.
well, it's not too gossipy for us. It's too gossipy anywhere, as
Yeah,
far as I'm
sure.
concerned.
Yeah.
I don't care a little state, big state, because I've lived
Right.
in both. So, how crucial is it for families' involvement in your work?
It's very important. I can relate to that due to my own injury.
What happened to you?
I was in an automobile accident in 1975.
How were you?
And I severed my spinal cord and became a C5 quadriplegic.
Mm.
And at that point in time, I went through some rehabilitation up in Burlington at the rehab unit, but the doctor there felt we should put Hector into a nursing home.
Right. That's all they had at that, but they didn't know much
Right.
else then.
So back to the caregiver, my parents said, no, Hector's not going into a nursing home. He's staying home with us. And I come from a family of 9, which was very helpful, and there was a lot of ups and downs. We went through a lot of issues.
Well, I would think it'd be very difficult. How old were you, Hector, when this happened?
I was 16 years old.
In the prime of life.
And so, yeah, the caregiver does a lot for their loved one.
And also, I have to say here, the spirit of courage and determination And moving forward in a life has got to be a very crucial aspect of a person being able to be successful in working with your agency.
Well, it is. It gives you a lot of strength, inner strength. And, it gives you always something to keep moving on, working forward.
Right.
Because you're always continuously seeing that you're doing better all the time.
Well, Hector, so I can sit here and tell that in all your years in your hard work, that from a tragedy, you have really encouraged the state of Vermont and done a lot of hard work and effort in really opening the doors for people with disabilities. So look at the wonderful work that you have done in these years. You're to be applauded and commended for your energy and drive and perseverance.
And it won't stop.
Well, that's right. I can tell that too, and I think that's important too, because there will always be people that unfortunately have automobile accidents or accidents through swimming pools, diving boards, all kinds of things that are very tragic, along with people who are born with disabilities. What would you say is the percentage between people who, like yourself, Hector, who are accidents victims, and those who are hereditary or born with the disabilities?
A person that is hereditary, a person that is born with a disability lives with that disability the whole life.
Right. But in the case, people that you work with in your case loads that you see, what would be the percentage? You would get 50%, 40% are accident victims as opposed to people who have a degenerative illness?
I would say it's 50-50
That much?
or about 60-40.
Really? And what would be the 60? The accident?
Yeah.
So it's people who really have used their arms and their legs and been able to have so-called normal, healthy existence that you did, and all of a sudden it was taken away for an accident or a tragedy.
Yeah, and then they don't know what to do with their life.
Right, of course.
And that's where we come in as peer advocate counselors, trying them to define what they need with them for another career.
And acceptance. I would think that
Acceptance.
acceptance would be a key factor here. I would also think certainly that legal rights are very important. If you've never walked the line, you know the legal rights, and you know what the legals for getting your driver's license, and everybody's been there and done that, and the legal book for taking the test to get your permit. But maybe the legal rights of a disabled person, if you haven't been there and done it, you need to know, because knowledge is power.
Yes, it is, and that again is where we're a big factor in it. We assist the peer with any type of assistance that they need to meet their independence.
I want to stress again two very important factors that we're discussing here at the Vermont Center of Independent Living. The first one is that there's no charge. This is a nonprofit organization available to anyone in the state of Vermont that has a disability, whether you are a child and your mom and dad and you call on behalf of a child and minor, or an adult. And the central office is in Montpelier. The second thing I want to point out is that the advocates, the counselors that are done throughout the state are people like Hector, who have been are disabled for one reason or another through a tragedy or illness that they have inherited and were born with. But they understand it, they are trained, they know the agencies, they know the community service, they know the legal and civil rights, they know the educational programs, and they can help you in every possible way, and there is no charge. It's very, very important. Once again, let's give the 800 number, 1-800.
It's 639-1522.
One more time.
1-800-639-1522.
How important, we've talked about the importance of the family support or the caretaker support, and we have to assume, and a lot of people would be family. How important is that factor of determination, that acceptance, number one, and the determination to want to continue on, and I'm going to continue my life, and I can find a way in which I can be valuable to myself and society, and not a poor me, why am I the victim?
Yeah, that's the number one, is acceptance of your disability. And it takes a long time before a person can accept their disability. Some people cannot accept their disability. Other ones are so determined that they're way up at the top. And once I have worked with a person that's really got self-determination, they're kind of like pushing me aside and saying,
I
I
don't
need your assistance, but let me follow through with the rest, and hopefully at that point when we reach my goal, then we can cut and let myself free, and you can go on and work with another peer.
What might you say? Of course, now I know the answer is going to be partially that every case is different, and every person in the disability is different in the case. But what would you say might be an average time that you, as a peer advocate counselor, might work with someone on an individual basis?
Okay, I have worked with peers from 0 to 3 months. I have worked with peers from 0 to a year. I've worked with a peer from 0 to 4 years. And at times there are peers that call the agency looking for assistance and then decide that they may not want it.
Oh, really?
Yes.
And what would motivate that?
Well, I don't actually know what would, maybe, again, back goes to family, that they found what they were looking for, and so they didn't need our assistance. Others call the center and are not self-directed. So when they call, they want a peer advocate counselor, but they don't know what they want. They do not know what they want.
Or they want someone to just come in and take over and do everything.
I could see that, yeah. One phone call and you'll handle the rest of my life.
Yeah, some people really hope that's what we'll do, because using that case management kind of model, or even sort of a home nursing, I'm mostly the case management model is a really good example of someone pretty much taking over your life, your decisions. Certainly within reason, but we try to stay away from that altogether.
Well, that isn't promoting what you're about.
Right, and it's not about. I mean, a lot of the times it's Hector was talking about different kinds of disabilities. I mean, sometimes it's something sudden that will be chronic. Sometimes, like with my sister, it was something sort of mysterious. She didn't know whether to accept it or fight it. And so she found herself in the middle. And after 10 years, she said, well, I guess this isn't going away. She also had trouble diagnosing it. So, in that way,
but that's probably a
different.
very rare thing.
Well,
Wouldn't it
depends.
that trouble diagnosing something?
Yeah.
Or,
Most
that's
things
gonna be long
probably
term.
aren't hard to diagnose. But I think one thing that Hector made me think of was that sometimes, like with multiple sclerosis, the severity of it can come and go.
Yes.
So some days
you have remissions.
you may need a wheelchair. Other days you're walking around fine. Or then you hope that you can just maybe hold on with the cane for a while and not go to the wheelchair. So I have a good friend with MS who some days she can horseback ride, and other days she can't get out of bed. So it's tough even on a daily basis to either accept or fight.
I would think so.
Yeah.
I would think it would be maybe more difficult for a younger person.
From my experience, it would be from a person from their at the age of 16 and up, because you're missing your whole life. You're dating, you're
Driving a
car.
Yeah.
What your life is going to be like in the future. Are you going to have a home? Are you going to have a family? When you have your disability, you're sitting back saying, now what happens?
Right.
Can I do anything?
Very difficult.
Yes.
Very, very hard. Also, we are talking with Matt Saltis, who is the educational manager for the Vermont Center of Independent Living. Matt, in your central office, do you have attorneys, psychologists, doctors, medical doctors who might be not right there, of course, but certainly on call or within your very near reach?
Well, we're not quite
for help.
Not quite that on-site specific or.
Well, I don't mean on site, but I mean where you might say, there is a particular counselor or therapist somewhere in parts of the state that deal with people with disabilities if you find somebody who's very depressed.
Well, we'd make sort of broader recommendations, such as this is your home health agency in your region, or often the visiting nurses are.
So they would
popular.
handle that.
Yeah.
All right. What about legal issues?
Well, we're part of a coalition in many ways with different organizations. There's the Vermont Coalition for Disability Rights, which is very lobbyist sort of focused. And if it's not lobbyist focused, I may be misspeaking, but it is definitely working for equal rights, civil rights of people with disabilities. And so they're going to draw on all sorts of experts nationwide. We're also part of the National Independent Living Center, or NICL they call it, and that's an oversight board and group that can really help us guide what we do, and it's a body of expertise to draw upon.
But I mean, I was more concerned about here in Vermont, like Vermont Legal Aid. Is it you work with them at all? Those kinds of
Yeah.
Vermont Tenants Association. I
Yeah.
mean, there's a lot of agencies
Yeah,
out there that can help people, I would think,
Oh yeah.
with disabilities.
Well, working on the phone,
Legalism.
we give out that information all the time. I've got,
Probably
bulletin board full of those
files
things,
of all of
and then
those.
all the pamphlets, and then all the new information that comes in, and you were going to
And
say
there's a developmental disability law project.
What is that?
That's where it's more with Medicaid and people that are not getting their rights.
For as far as getting medication and medical equipment, things like that, has to do in the medical end.
That's the medical end. And that's where we go with the developmental disability law project. People that have a, like you were saying, a psychiatric disability.
Well, if they could, or just the fact that, as you say, someone who's gone through a terrible tragedy, and the acceptance can put a person into a state of depression and need, psychological counseling or therapy, either short-term or long-term.
And that would be my job as a peer advocate counselor to assist the person to find that information. And we're always doing research.
Always. You're really an information center, even on a local level. This is Hector Racine from, we're actually located in the Brandon area, but he handles all of Rutland County.
Yes.
And so there's constant calls. There is a waiting list. Is there a waiting list around the state?
Well, it depends. It's always different. We get a weekly update. So some people, it depends how many peers the peer advocates, counselors finish up with in a particular month. Sometimes it feels like all of the calls are coming from a particular area, so we swamp one person. But so it always depends. Sometimes we put people right through, and other times it's 5 weeks.
But still, a month isn't bad at all when you think about
Yeah, I don't think so.
the whole realm of everything. To wait a month when maybe somebody's been hospitalized a long time, or I suppose in some people could think of a month. Oh my gosh, it's another whole month.
Right.
And then on the other side of the coin is, I'm sure in other states and in other cities outside Vermont, there could be thousands. There could be a 6-month or a year waiting list. So it's all relative. Everything is truly relative. How many peer advocate counselors like Hector do we have throughout the state of Vermont?
I believe it's about a dozen.
We've got 14.
14. And they go in virtually every county?
We try to cover every county. I do Rutland and part of Addison.
Oh, you do?
Yeah, people pick up various pieces here and there, but anyone can call from anywhere, and we'll know who to send their way.
Oh, I'm sure.
So,
yeah.
So we will go everywhere, of course. Sure.
And Hector, you drive?
Yes, I do. I have an adapted van that I drive. I get up, in the morning and get dressed, have my meal, and out the door I go.
And you live by yourself?
Yes, I do.
Independent living? So you are living proof that it can be done in a very solid and fulfilling life.
Yes, it can be. I've got the home health that comes in, and I'm under the Medicaid waiver program, where they come in and assist and get me dressed, do your personal hygiene, prep your meal, and pack a lunch. You're set for the day.
So you're on the road. You said you do this part-time. How many days a week? What is considered part-time for you, Hector, that you're doing this?
Well, part-time, I like to do, part-time is 20 hours, but I average about 30 hours a week.
So that's divvied up so many hours per day, or absolutely, I'm doing Monday, Tuesday, and Wednesday, and then Thursday and Friday something else. How do you divvy that up?
Yeah, you try to divide it up so that you're free with the phone, so that you can make phone calls to your other peers that you haven't contacted, and follow up on making sure that they made their phone calls for what needs that they needed to be met. And if they haven't, then do a 3-way conference with them, which I do. I do a 3-way conference. I will call my peer, and if they say, well, we didn't have time to make the call, or I didn't have no energy today, then we would say, okay, let's get on the phone right now. I'll make a call to
Wherever.
wherever it may be, and we would settle it there. So I do at least 50% of my communication by phone, if not more.
Now this 800 line phone number, and we'll have you give it again before we go off the air because we're winding down on time. Is that a 24-hour, 7-day a week, or not?
You can certainly leave a message, but it's pretty much 9 to 5.
A weekday, because you were
Yeah,
a regular
to get a real
Vermont
live
agency.
human.
Right.
Yeah. And
I know when I call, I get Rosie.
Right.
Hi, Rosie.
Yep, Rosie will help you out.
Yeah.
And she'll direct any call that doesn't have a clear, program. If she doesn't quite know where to put it, she'll just send it to INR. So, but you can also call up and simply ask for the information and referral person. And we do our darndest to get somebody, a real life person there. And their meetings are they're this and that. They're sometimes it's hard, but we really do. That's one of the priorities we have, is to make sure that people really talk to a person. So we're going to make an effort to do that. So pretty much 9 to 5.
We want to also say that you have wonderful brochures that are available. Again, this is a nonprofit agency in the state of Vermont, there for your help and guidance, and you have getting the answers you need. All about
advocacy.
Your resource center. And the library on independent living, a home access program.
Yep, helping with entranceways and bathroom modifications.
And exactly all about what is independent living. I have all my brochures here. And
our philosophy.
And your philosophy, which is? Want to sum it up again for us?
Sure. Well, I would say it's to empower citizens to more fully live in their communities, to access the things they want to do, to get out physically into the communities, but also to enjoy media if they have a sensory disability. So it's all about being more fully integrated, working with individuals as well as whole systems to increase access.
A minute ago, or a short while ago, it's been a few minutes now, Hector, I asked Matt a question. I'm going to ask you the same question in your interpretation and your many years of working here in the state and as a peer advocacy counselor. What do you feel really needs more attention here in Vermont?
I have got to agree with Matt that it is transportation, because I've worked with many peers, and through the Center for Independent Living, we have get them a ride through the Medicaid service system, or the Center for Independent Living through the Independent Living Resource Program. We have vouchers for travel reimbursement.
Oh, you do?
Yes, we do.
Huh.
So yes, the transportation is a very large issue. And I have a man that they don't have a bus in the state of Vermont that can get him onto the bus with his wheelchair.
Now you're talking about a municipal bus around town, or you're talking about a bus to go from one part of the state to the other, without mentioning any particular...
That's right across the state.
Right across the board, okay. Very interesting, isn't it? Which brings up another issue. Talk about transportation. I'm sure there's got to be people who need transportation who are in wheelchairs or whatnot, just to the doctor's office.
Absolutely.
Can't get into a car.
And also
utilize an ambulance every time.
Another issue is if they do indeed have a ramp up to the front door of the doctor's office, can they get up on the examining table? Can they use the facilities within the office? And as now Medicaid is coming in and transitioning a lot of people from Medicaid to a managed care program or other. There are a couple choices. But what they're finding is that they're doing the research on access to a lot of these local doctors, and they're finding that access is terrible. So even if you can get to a doctor's office, often you can't get examined in a dignified manner.
Well, I can tell you an experience, because I took a terrible fall in November. I was laid in bed for about 5 months with broken bones and whatnot. And I got to my doctor. I had the ambulance, no problem. The ambulance came, took me down the stairs, got up the ramp into the doctor's office, but the door opened the wrong way. So here I am trying to get into the doctor's office and the door opened toward me.
Mm-hmm.
Now when you're out in a wheelchair with your leg is in a cast sticking out, I don't know how anybody figures you can open up that door and get through it.
And the other thing,
Those are little things that you don't even think about. And God rest in peace, mine was but those are just an experience that I had about it's handicap accessible only to a point. Mm-hmm. And then the other point is you can't open the door, but you better watch out somebody's not coming through because they can whap you. I've been there, done that. Mm-hmm. So small things become big things.
Sure.
And
Yes,
that's the issue here.
Mm-hmm.
And we are talking with two terrific gentlemen from the Vermont Center for Independent Living. We have Matt Saltis, who is the education director. Mm-hmm. And we have Hector Racine, who handles part of Addison County and Rutland County and resides in the Brandon area. Can be reached. Any advocate, counselor throughout the state and the office is an 800 number.
That's right, 1-800-639-1522.
I'll be saying that tonight when I'm going to bed, 1522. I'm Pati Papineau, and this show is about living with dignity and fulfillment and finding courage and hope and perseverance in life. And until we meet again, I'm Pati Papineau. I thank you for bringing me into your living room. Until I see you again, please be happy and drive safely. Hi, I'm Pati Papineau. Welcome to my show. This is a really interesting show and very valuable show if you live anywhere in the state of Vermont, but especially locally, because we're going to talk about HealthLinks. And that's an organization which is nonprofit that began in 1994. And it's over 50 local community agencies, if you can believe that. That's an awful lot, that are out there to help people in need in many various aspects. And we're going to talk about some of those specifically with Betty Spooner, who is an employee of the Rutland Hospital. And she's involved really directly in a couple of these programs, Bridges and InfoLine. But we want to talk about all of it, let people know that it's out there and exists and how it works. So I welcome you. I have lots of questions because I've just learned about this myself. Started in 1994 with Dr. Gorman.
Yeah, it started out of a program. Dr. Gorman was something called the Pulmonary Pilot Project, and he was working with, he's a pulmonologist in the Rutland area.
Know him well. He's my dog. Oh, yes. I have asthma.
And he worked on a project sort of between the hospital and VNA. And they developed some environmental screens and worked with a whole project of folks with chronic respiratory disease. They were trying to determine, one of the things they're trying to determine is what items in that person's life prevents them from living independently. What risk factors, what things could you fix that might help them to not go back in the hospital or not have to be in a nursing home and to stay and live independently. And one of the things they discovered, one of the big things, was lack of knowledge as to where to go to find out what resources are out there.
Right, and what agencies are available.
That's right. Rutland area has a lot of things going on to help folks in a variety, and it was more the non-medical kinds of things. I mean, if they were ill, they knew where to go.
Right, of course.
But for all of the other kinds of things, whether it was help with financing for home and heating stuff or food or support groups or family issues, all that kind of thing. And they really noticed that was a big gap in our community, one place to go. I mean, a lot of agencies know what they do and they know what some other agencies do, but there wasn't one place to go to find out everything. And so that grew, a group began meeting, and it really kind of mushroomed. I mean, they talked more about it wasn't just chronically ill people, it's everybody. Everybody needs to have
Everybody
that
has a
service.
need at some time.
That's right.
That's right.
And so they really decided that it needed to become a little more formalized. And one of the things we said, well, there's printed directories here and there out through the community, but they outdate quickly. They were usually very specific to certain type of services. So they wanted a computerized database, something you could update quickly and be accessible for people just by a phone call. You know, a phone call that didn't cost them anything. And one of the first ideas was to go to IBM to see if we could get a computer donated or something.
Right, yes.
One of the first things they said was that you had to be a nonprofit organization before they would make that kind of donation. And we realized to do any fundraising or any of that kind of stuff, you really need to have a little bit more formalized. So they developed a board of directors. They became nonprofit and tax exempt. And that really kind of grew. And that actually happened in '96. By the time all this happened, they became incorporated in '96. And from that developed a database, and we've been working with that, and it became what is now known as the info line. We felt the name for something for a telephone line, and HealthLinks has continued to sort of mushroom. It's become an umbrella organization for a number of different initiatives throughout the community, and we can talk about a little more of some of those a little later.
I think they're very important because, as you say, everybody has a need. Whether when it's come home from the hospital, you have a need, or before you go in, or some kind of a need. There is a clinic on Park Street in Rutland where you don't have to have any medical insurance. It's not a requirement.
No, in fact, it serves people who
don't
don't
have it, which
That's-
is even better.
that's
People
what
of low
it's-
income
yep,
with no
for-
insurance.
yep, with no
So
insurance.
there are all of these wonderful community, local agencies that exist for all of us, for one need or another. It doesn't, and this is certainly not HealthLinks, and all of this is not have to do with people who are low income. It's for everybody, because everybody has a need at some point or other.
That's right. People that are new in the area. We also have available in there agencies who have speakers available to go to places, people who, agencies who might need volunteers, or so somebody wants to know where they might be able to volunteer. That's an item that's in the database.
And we should say that being a nonprofit, it is staffed by volunteers. Very important. And also, we're going to talk a little bit about this info line, but we want to make it very clear to everybody that the info line is limited on staff, so it's not a 24-hour, 7-day-a-week availability. You call, if you don't get through the first time, it's okay. Leave a message or call back a second time, because it's still, everything, has to grow and bloom and blossom and needs volunteers and work, so it's not going to be there instantly, maybe, depending on when you
And
call.
there is voice, there is voice. I know people don't always like voicemail, but you can leave a message, and we will call you back. And we want to make clear on that. We will, may not be that day, but we will definitely call you back.
Well, we also want to say that if you feel that this is a worthwhile, certainly, I do, organization, and you have an hour or two that you would like to volunteer, just to answer some phones or to get involved in one of these wonderful projects, that they can certainly call you at the Rutland Regional Medical Center.
Absolutely.
And there's an 800 number. Let's give out the 800 number.
Okay, for the info line, the 800 number is 888-718-8855.
And we have that on the screen. We'll do it one more time. 1-888-718-8855. Or the Rutland number would be
747-9961.
And there again, we've communicated many times for the last several months through that telephone number, and you also are limited hours, but there again, just call and leave a message.
That's right.
Trust me, it works, because that's how Benny is here tonight. This is the first time we met, just before the show. We both live in Rutland, but we've communicated through voicemail and all of that.
That's right.
So it's efficient and it works, and please utilize it.
We're actually physically based, the info line is physically based at the Park Street Health Share location.
Is it?
We share space with them.
And
so it's a wonderful...
What number Park Street?
88 Park Street, and it's
Okay.
actually in the VAC building. It's on the...
No,
sort of the
well, let's say what the VAC is
I'm
for
sorry,
anyone not know.
Vermont Achievement Center.
Right.
And that's on 88 Park Street.
And that is just past the Rutland Fairgrounds. If you go down Park Street and you go past the Vermont State Fairgrounds, it is like a big building on the left. You cannot miss it.
And it's just past the Park Place Florist. If that's the driveway
Well-
right after that. But if you're on
Okay.
Park Street,
If you're going to Park
see
Street,
that, yeah.
So we began in 1994. It got incorporated in 1996 and has grown, it really mushroomed into all of these agencies. Can we talk about some of these agencies, and then before we get into specifically Bridges, what you're involved in?
The Bridges and the Infoline are the two projects that HealthLinks really actually runs. And then there are a number of organizations like the Park Street Health Share. There is the Family Ties.
And what does that do?
They are they work with, it's their theory is families helping families,
Right.
So that it's not necessarily, you're not going to necessarily like a professional counselor,
Right.
but it's people who have gone through the system, whether it be the welfare system, the education system, the court system, different family court, those kinds of things, and they're really there to be an advocate. They give empowerment training so you can advocate for yourself and for your children. It really is, again, families helping families. So they really, people who have really been through it and can sort of walk the average person through it and be that support for them.
It's so important because most of us, a lot of them don't ever go through things, and when we go through them, even in surgery at a hospital, it's nice to have somebody there that will help you and guide you. PALS. It says pathways to my handy dandy paper. Can I read from my handy dandy?
You
I'm going to
absolutely
cheat.
can.
Pathways to alternative learning skills. And this is, it says everything. Educators, parents, students involved with people who have learning disabilities.
Right, and that's what it's geared for. And I'm not directly involved with that group, so I'm not as well versed in how to, explain exactly what they do. But
Well, I know. I just thought we'd
Yeah.
touch base because people are tuning in all the time and they're seeing HealthLinks, and we want to explain that it is many, really over 50 agencies, which is too numerous to mention in this show. But to touch base a little bit on what's out there and to call and then get a person who really is, trained in that agency and that specific project to give you real specific information. Now, the Rutland Asthma Program, this is probably self-explanatory, people who have asthma.
and that is Dr. Gorman's, is kind of the continuation of the Pulmonary Pilot Project that got this whole thing started, and he continues to work with that. And again, I'm not really well versed in all the details of what he's doing. A lot of these affiliates of HealthLinks that we're talking about now are, they have their own mission and their own board, and they, HealthLinks is overall responsible for them, but they operate somewhat independently in that.
Which is good because
yeah.
independently, then they can work and they have a little more flexibility than if they were on a very, very stronghold position.
But we do
by the
oversee
board.
the operation of all of them because they're under our nonprofit status and insurance and all of that. So
So we have the Rutland Area Long-Term Care Coalition. I suppose, now this is over 20 agencies to serve the needs of elders and disabled individuals as well. And it works with the Vermont State Department of Aging and Disabilities. And this certainly, we're talking long-term care, people who might be terminally ill or whatnot. But
long-term care,
long-term for me as opposed to short-term, because I'm seeing this all through this
looking more
paperwork.
toward long-term care, more specifically for the nursing homes, community care homes, those kinds of organizations.
Where you might be over a
The
period of
Council on
years,
Aging,
long-term would be years,
right.
as opposed to weeks.
Yeah, and long-term care is sort of the healthcare field. We think of the long-term, like residential care, community care
Residential
homes,
care, okay.
those kinds of folks. But involved in the coalition is, a lot of hospital representatives, Council on Aging, the BNA, again, the nursing homes, all the different residential community care homes in the area. It's quite a large group, and they're really right at the point now of sort of regrouping and restructuring a little bit and finding out how they can best meet the needs of the community and what's missing still in the elder population. Elder and disabled, I want to stress. It's not just elders, but it's elders and disabled. One of the things that has come out of over the years, the Long-Term Care Coalition, is the InterAge Adult Daycare Center, which is in Rutland now. And that was a very positive thing that came out of that group meeting and identifying that's a gap. Folks that have caregivers that work and they can't be alone during the day. They need some sort of adult daycare. And the InterAge was a direct result of this group meeting over the years.
So it's safe to assume that that's complementary to a child daycare. A person that is in need
That's right.
and needs of supervision goes like a child would for so many hours in a daytime, and then they're picked up and brought home.
That's right.
That's wonderful.
Meals, and they have activities, and they've just moved to a new location next to the Grace Congregational Church in Rutland, a house there. So it's a wonderful, wonderful program. I think they're full.
Is there a fee for that?
There is. It's on a slide. I believe it's on a sliding scale, so there is a fee. I don't know what it is offhand.
Now, what are they called? Well, what are they specifically called? We can have people call directly.
InterAge is
InterAge in
is
Rutland.
the name of the
And that's
the
for
organization.
elderly daycare.
Elder or disabled. I
Elder
believe.
or disabled
Either.
daycare.
Yep,
So it's
I
a
believe it's
short-term, daytime project.
Yep. And you can, they're open 5 days a week, so that I think you can, and you schedule, whether you come, you don't have to come every day, but it just, there's a.
So the best thing is for somebody to call them directly and find out what their schedule and their needs are, but that's okay. I'm sure they're in the phone book, Interage, and Rutland County Triad.
Triad.
Triad, okay.
That's okay.
All right.
And that's actually, the Rutland County Sheriff's Department is kind of the group that, I'm not sure if you call it managing it or whatever, but they, the ones, and their project is to identify, and I think it's primarily for elders, to identify what the criminal aspect of what fears people have in their homes. So they're looking for, they did a survey, in fact, a community survey of a lot of, like Sheldon, some of the subsidized housing for elders and disabled, to identify what fears they had in their own home and what could this group do to institute things that would put people, make them feel more comfortable in their home. So it's trying to minimize the criminal
fears
and
I'm sure a public awareness,
I guess, of
a
the
public
elder
awareness for the elders of maybe scams and ways that people that take advantage of them because they are elderly. Yeah. So this particular program is run by the Rutland County Sheriff's Department specifically for senior citizens, and it has to do with law enforcement issues. Right. And I would say the best thing to do would be call the Rutland County Sheriff's Office, and I believe it's Miss Underwood that you would ask for, Sharon Underwood, Lieutenant Underwood, and talk to her and ask her how she can help. We want to also say, I would assume from what you said earlier that somebody like Lieutenant Underwood or yourself would be available to go and talk to senior citizen groups or women's organizations or professional organizations to let you know what is available out there, if not for your own self or your own family, extended family.
Yes. And Triad, actually, I think it's a national program of sorts, but in each county, each state, it's sort of handled differently. They have different focuses, and so I'm sure Sharon would be interested in speaking to groups about it.
What this whole program about with Betty Spooner on HealthLinks has to do with knowledge is power. And that's something I've said many times on the show. And it's as simple as that. The more you know, the more you are empowered, the more you can handle things, the more you can cope, the more that you are able to live on a day-to-day basis more successfully. And it just helps you improve the quality of your life. You don't have to be sick, you don't have to be elderly, you don't have to be disabled. All of these agencies help all of us. And there's even one group, GriefWorks, it talked about bereavement services, which we all need. Everybody on the face of this earth loses somebody that they love.
That's right. And
we have to learn, what is it, not to feel that your grieving is so long-term that you feel out of place or you have a tendency to withdraw, and to learn to cope with those feelings and all the rest that goes with it, maybe guilt or unhappiness. And even I'll go so far as to say that maybe they would even have to do with grieving of a pet. I mean, there are people and senior citizens who lose their pets, that is their only family and the only link to life itself. And I think that that's absolutely important.
Yeah, they're trying to pull together, increase awareness throughout the community and pull together bereavement counselors in all different aspects, whether it be trauma or the more long-term or suicide or any of the different, situations where people are faced with grief. And they're really trying to pull that together. And they've sponsored, I think it's been 3 now, hospice teleconferences, and they had one just recently. It was quite well attended. So,
well, there again, it's a need and it's a gap because everybody loses somebody.
That's right. Yep.
In this world. And if you don't learn to cope, it affects you. That's right. It affects your life in every negative way. I guess we've hit all of these. We've talked again and we want to touch, there is under HealthLinks, the 50+ agencies that are available to all of us. We're talking students and teenagers and parents and senior citizens and disabled people. People who are in need with medical attention, people who are in need of all kinds of services and agencies that are basically free or next to free out there. And the HealthLinks clinic located at the Vermont Achievement Center on Park Street in Rutland is a clinic. And you do not have to have, and it's geared for people with no medical insurance.
That's correct. And it's not set up for emergencies, however. They have one clinic per week at this point, Tuesday evenings. So you need to call.
You need to make an appointment?
To make an appointment, yes. They aren't staffed for emergencies. They only have the one night a week. And it's all volunteer. They're except for one. The director is paid through grant money through HealthLinks.
Is that a doctor?
Physician? No, she's a nurse.
A nurse, okay.
Is the director, executive director, Diana Matthews. But the physicians and the clerical staff and the other staff that assist in each clinic are all volunteers. So again, it's a strong volunteer effort there.
Well, if you think over 50 plus agencies, you must have hundreds of volunteers if you really added them all up and put them all together, because nothing runs nonprofit by itself.
That's true. And the agencies that are members of HealthLinks, there is no membership fee, and if there's somebody out there watching this show who participates in a health human service or some type of agency, or if you're just interested in what HealthLinks is all about, we encourage anyone just to come and see what the meeting's all about. They meet quarterly, the membership meeting. We have a board of directors.
Where do they meet?
We meet at the hospital. The next meeting is Friday, July 30th at 8:30 a.m. and it will be in the Rutland Regional Medical Center Conference Center. It's in conference room number 1.
I want to stop you though right there, just in case this show might not air until after that. We don't usually give out specific dates.
Okay.
The best thing for people to do, if you would like to participate, which is a wonderful thing to see what goes on and how it works, and its inner tickings, they do meet at the board meeting. Call the Rutland Hospital or call Betty Spooner's office.
Calling me,
and she can give you the specific information, and disregard what we just said, because we don't want a problem. Suppose something happened and that meeting got transferred or the show didn't show. So that's better.
That's true.
Better to get it,
but
to call. It's a quarterly meeting. It's wonderful. You have a board of directors.
It's a membership-driven organization, so we have a board of directors who, make recommendations and meet for the operational parts, but we are membership-driven, so that no major things happen without the membership voting and supporting.
Who are some of the members of the board of directors?
Well, the president of the board is Dr. Jim Gray. The vice president is Martha Barrow-Steele, who's with PSA Healthcare, which is a home health agency in Rutland. We have representation from the hospital, from VNA, from a retired physician who's involved with Head Start. We have
lots of people. We have lots of people. Yeah. And how does a person become a member of the board?
We have elections every year. It's a 2-year membership, so we just had elections. It's a staggered membership, though, so some people, every year, someone is always going off the board. You need to be a member of the organization first, and it's good to have been to a few meetings to know what we're all about. But if you're interested, when it's our annual meeting is in January, so it's a calendar fiscal year. And if people are interested in becoming involved, I encourage them to attend the meetings, and then they can nominate themselves or get someone to nominate them when it comes time for elections. We encourage varied representation, so we certainly want not everybody on the board to be from one organization, obviously.
Obviously, right.
Yeah.
Well, let's talk specifically about Bridges, which is your specialization.
Okay. Bridges came about through a recommendation through the Southwestern Vermont Council on Aging and at the Rutland office. And they had identified through their work with elders in the community that when elder folks go home from the hospital, if they are isolated, if they have limited or no family in the area, because people are in the hospital less time than in the old days,
This is true.
Tend to be a short time. So when they go home, while they're physically able to be home, emotionally, mentally, they may just be uneasy getting there again. You get all this attention in the hospital, hopefully. And when you go home, it's like getting settled again. And if they've been in the hospital for any length of time, they may need to restock their refrigerator, cupboards, and if it was an emergency admission, they may need to clean out. There's a lot of things that they could be
They may have laundry issues or
absolutely, and they still
medication issues too.
If they've had a surgery or a stroke or something that
traumatic to them,
back on their feet yet, haven't got their strength quite back, then they may have those needs. And if they don't have, again, family or a lot of friends that can
pinch hit,
that's right. Then we wanted to be able to provide, again, volunteers. There isn't a lot of money for these things, so volunteers are very, very valuable. To be able to help get that person home and sort of bridge that gap. I mean, sort of make that that transition home a little less traumatic for them, and get them settled. We even have some volunteers that will stay overnight. Not many people will do that, but because they have families and so on. But there are a few volunteers in some situations who will stay overnight with someone. We have that happen if someone comes in for an outpatient surgery, and they don't need to stay in the hospital overnight, but the hospital doesn't like them to stay alone. And if they don't have family again,
It makes it complicated.
Yeah, so they can go home, and this person can either stay overnight, or in some cases they may not need someone all night, but someone to be there, check on them the next morning.
So this
help
is
them get a meal that evening. Make sure they're settled and comfortable and okay in their home.
This is a short-term
It is.
care. Bridges is.
For the most part.
And let me just ask. So it's a short-term care, so that I'm clear. So somebody might accompany a person home, help them get a meal or get situated at home in their bed, or help them change their clothes or unpack or get groceries in or whatever the need might be at that particular moment. Then they might come back another day or 2 or 3. It's not just for that particular moment when they get home from the hospital.
Not necessarily. It's really on a case-by-case basis.
Case-by-case need.
And sometimes we find that, of course, again, if someone's has a planned surgery, they may have family from out of state that comes up, to be with them during that time. But then after a few days, they need to go home, and that person still may not be quite able to do everything around the house, or may still need somebody to check on them, or want that moral support, emotional support, any of that kind of thing. And so we'll have volunteers that will go in sometimes a week or 2 after they've been home from the hospital. Try to be very flexible. We really don't have necessarily a textbook case, because there's so many different situations.
So each individual, I would think.
That's right. And sometimes we also have had, if there's a couple living in the community and say one's a caregiver for the other, and that caregiver either is out of town for a day, gets ill themselves, has to go in the hospital, any variety of things, or maybe just needs a break, needs to be away for a reason, then we'll send a volunteer in to stay with that person if it's somebody that can't stay alone, or again, check on them, sometimes even just by phone, but usually it's going actually into the home, spending a few hours with them, kind of a variety of situations. But pretty much at short term, as opposed to, and I do get calls for somebody needing somebody to visit on a weekly basis, indefinitely. Unfortunately, we don't at this point have the volunteer pool to be able to do that, but we are working with VNA. We're sort of on the brink of trying to expand the program to being called Bridges and Beyond.
Well, that could almost get into other programs for the Long-Term Care Coalition or whatnot. It might have other agencies or other areas of HealthLinks that you would direct them to.
And actually, funny you should mention that through the Long-Term Care Coalition there has been some state funding that has, part of that's going to be used to try to do exactly that, expand the Bridges program and working with the Council on Aging and with the whole coalition and with VNA to allow maybe volunteers to go in on a more long-term basis to check on people. But the thing that is pretty common throughout all that is that it's non-medical services. We aren't, the volunteers are trained to the point of being aware of different situations. A lot of my volunteers actually are retired nurses or have provided this kind of care either for a family member in a job, and that's why they want to do it. They've either retired from that or they find that missing in their life and they still want to provide that kind of care. But we do provide some training, but they're not required to have any medical training. So we aren't able to do a lot of like what nurses' aides would do.
Well, you're not a medical agency. You're not a visiting nurses association. You're not.
Sometimes people
you're a health.
And they really look for somebody to do.
Well, let's make that clear.
That's right.
You're not a visiting nurses. You're not a home health aide.
That's right.
You're there just to give some kind of
they don't do
limited, helpful
they don't
support.
That's right. It's more emotional support, but they will run errands. They will do little things around the house. That they can't reach something or clean a certain area. We don't do whole house cleaning, but little things that will help again get that person sort of settled back and help them to continue to live independently, which is the real goal of the program, so that people can stay in their homes and not have to go into institutional living any sooner than necessary.
How many volunteers do you currently have in Bridges?
I was going to take a current count. It really changes quite frequently. I just added, I'm very fortunate to just added like 4 or 5 new volunteers who are just sort of in the process of getting up to speed, on what they need to do. So it does fluctuate quite a bit, somewhere in the neighborhood of probably 14.
And they are So for everyone who's watching, we're talking about HealthLinks in Rutland. It's a nonprofit organization of over 50 agencies to help people, all kinds of people from all walks of life. We're talking specifically about bridges to help people really coming home from the hospital or surgery and that sort of thing. 14 or 15, we're talking, these people are 7 days a week, so I mean, if somebody needed help on a Saturday, they might be available, or is it strictly Monday through Friday?
It might be, no, it really varies. I have some, and my goal is to have as large a pool of volunteers as I can,
Right.
so that
It's divvied up.
it is, and I stress, one of the things I think is a benefit to the volunteers is that we have a menu of choices of things that they, services that we are willing to provide, we're able to provide. And the volunteer really tells me, I don't like to do this is what I prefer to do, I have this particular interest, and this is when I'm available, don't bother me on weekends, or I can only do it on weekends,
Right,
or so,
right.
so it's very different for every volunteer, and it's very specific to what they're willing or able to do. So then when I have a need come up, then I'm able to match, hopefully, with we never can make any guarantees, it is a volunteer program, obviously, but we're really pretty successful in being able to find volunteers to meet most of the needs.
So if I am to be correct from what you just said, you have here the patients who are coming home and the people in need, and on this pool you have your volunteers. So do you have your volunteers work a specific shift, and then where the need is, they come, who's ever on the shift, or you have a more specific coalition here where that patient A has a need and volunteer A likes to do that sort of thing, so you contact
That's right.
and link up these two people.
That's right. And because, again, it's a volunteer program, people tell me when they're available, generally, but they aren't required to be available at that
Right,
time.
of course.
So again,
course.
it's volunteer.
Right.
So what happens, for anyone calling with a request for the program, the more notice I have, the better. Because, I'll try, on as short notice as I can, but certainly the more notice I have to be able to get hold of people, to be able to make that match, to meet the person if they're not in the hospital. This
It's
program
better.
is based at the hospital, so if it's someone in the hospital, I can meet them. I can even sometimes meet family if they're there, and that's really great. Sometimes I don't have that opportunity that day because they're in the community, and so in those situations, it's all the more important that I have a little more notice, so that because it involves talking to people and contacting the
Oh yes, it's a very. This is not an easy thing to put together. It's not to say, well, so and so will be there at 6 o'clock to pick you up. It's not like that.
That's right. Because the
And,
volunteers, again, they say, well, I'm usually available, Tuesdays, Wednesdays, and Thursdays, but they're not going to sit home by the phone.
No, of course.
Because, and I never know when, I get referrals from all
And that's
over.
my other. How do you get your referrals? Do the patients call you, or does the hospital? How do most of your referrals come?
It's, again, kind of all over the place. I get referrals from social workers, nurses, doctor's offices, patients themselves that become aware of the program through various ways, the brochure or wherever they've seen it, or repeat users. I'm finding more and more
Yes,
now.
of
I get
course,
people who've used
sure.
the program, or I've had a family member or a friend who have used it, and so then they will call me directly. Council on Aging, some other agencies like One-to-One program, which is a program out in the community, and they provide primarily transportation to doctor's appointments and grocery shopping for the elderly and disabled population. And sometimes that's their primary function, but we kind of work closely with them because there's also a volunteer program, so if they have a need they can't meet, because my volunteers will do that in conjunction with other things, sometimes we can fill in a quick gap for them if it's just a quick trip one place or another. So we help out that way. It's really quite a variety of places. And the nursing homes, the other thing that the volunteers we've kind of expanded to doing is that the nursing homes will call us if they have a resident to go to a doctor's appointment and there's no staff to accompany them. They send them on the bus. They don't have to, the volunteer doesn't have to drive them, because they're usually in a wheelchair. But it's a real great benefit for them, so they don't have to, the staff, they're short-staffed as everybody, so volunteer will go and accompany that patient to the doctor's appointment and accompany them back again.
How many patients per week does Bridges assist?
Boy, that's hard to say. Should have committed my statistics to memory. We do annual reports every year in statistics. Let's see, I think last year, it varies quite a bit.
Of course,
I mean, I can
but
go,
just a ballpark.
I'm going to say 5 to 6 maybe a week.
Okay.
And it really can vary. Some days I'll have, for if you know, I'll have other things just pending.
Right.
Other
Like
days
everything
it's
in
crazy.
life, you know, it
That's
changes.
right. I think last year we helped, since the program has been in existence, which is July 96 is when we actually first started serving patients, we've served, it's probably close to 300 now.
That's wonderful.
That we've actually...
All through the
and
community,
I-
not just people who live in Rutland.
Quote me on that number, but it's very close. I mean, it's quite a number of people that we've helped over a period of time.
Now, just to switch tables here a minute, on your volunteers, somebody can't just call up and say, I want to volunteer. They have to fill out a form, I would imagine.
Unfortunately.
Well, I would think so. This is
Yeah.
we're in a day and age where you can't just take anybody off the
That's
street.
right. And-
Unfortunately, it'd be nice to say,
It would
but they
be.
have to fill out a form. They have to give references, social
That's
security
correct.
number. They
Yeah.
cannot be convicted felons.
That's right. We do background checks through the
Do-
adult abuse registry as well as criminal background checks
Right.
and driving record checks. And it's, I mean, and for all the people that I've ever interviewed to want to be a volunteer, it's almost embarrassing to make them go through that because you know they're wonderful people. But as you said, and it's nice to be able on the other side to tell a family member, especially one who lives out of state, and I'm sending a stranger into their
I
mother's
don't care.
house.
Even if
know.
you're not out of state, if
Well,
it was
yeah.
for somebody from my mother,
That's
I'd
right.
want to know, does
You
this
wanna
person
know
have a valid driver's
every
license? Do they have
check,
any
that's
marks
right.
on their driver's license? Are they a
They do
convicted
so.
felon? Are they a United States citizen?
Yeah.
I mean, that's all to me
Absolutely.
very, very valid information.
And we
I'm
have
letting
to-
somebody into to help a loved one and into a home environment.
That's right.
A privacy of someone's home environment. So,
Now, if someone
it's
is
important.
already a volunteer at the hospital, because they already do that,
well, they've already filled all that
right,
paperwork.
we do at least try to minimize, paperwork so that we don't make them do it again if they've already filled that out for some other volunteer situation where they've already had those kinds of checks.
And I'll interject here and say that I have a teenage daughter, and when I first moved to Rutland, she had thought about volunteering as a candy striper at Rutland. And I did that years and years and years ago. And then I got a packet in the mail of a booklet of questions for her to answer. So it is, unfortunately, to our viewers, this is the day and age in which we live. And sometimes it's better to be safe than sorry.
It is.
And to check everybody and to have a health exam and to know all these questions. Again, knowledge is power. And it's important that they go through a screening process for volunteers. And we want to make that very clear. This is, again, HealthLinks. It is over 50 agencies, local agencies in the community to help people. And it's run as a nonprofit, started in 1994 by Dr. Gorman, who is not only my doctor, but I invited him to be on the show to talk about sleep disorders. I didn't know he was involved in this too. But it's a nonprofit, so you are staffed by volunteers. And that it isn't just anybody that's a volunteer. And I think that's very important to give people who are involved in this, and the parents or caregivers or family members, whatever, to know, give some sort of peace of mind. I think that's very important today.
Yes,
It's a necessity.
it really is. And my the hospital kind of donates my salary to coordinate the Bridges program, can't say it, and to try and get the InfoLine program off the ground, which we're pretty close to doing. So. But
Well, everything falls in
else
place
is-
in time. It doesn't, sometimes things take time to blossom and grow normally. And you have to work out the kinks in every organization. And I can tell you, I've worked with volunteer organizations most of my life. And it's a very, very careful line. You have to, more difficult to me, to work with people who are staffed and volunteers in nonprofits, because I just think that they're in it hopefully from the love of their heart and because they want to be there, and those people really need an extra pat on the back and an extra thank you, and a appreciation goes a long way to people who volunteer.
Absolutely. And we do.
And that's real important to keep good volunteers.
It's
you
crucial.
know,
It's
appreciation
crucial.
goes a long way in society, but certainly a long way with people who are donating and dedicating countless hours to
we
something.
do our absolute best to let them know, never to take them for granted, and always let them know how much we appreciate. And we do plan recognition ceremonies, luncheons,
It's
and
important.
We'll give away things as much as we can. We don't have a lot of funds, but you can. Doesn't necessarily cost a lot of money. to
I
say
don't think a
you.
thank you costs anything, but it sure is a great thing to do.
Yes, it is,
you know.
and it's very, very important.
Something else that we didn't talk about on this list under HealthLinks, now there's 50 plus agencies, and I said earlier it was impossible to go through all of them tonight. We can't do it, but this for Volunteer Guardian Task Force. And it helps probate courts maintaining an adequate pool of volunteer guardians. So they're assigned, these are assigned by the court. to help or assist people in need through the court system.
And they're volunteer. I guess
Right.
and one of the reasons they became an affiliate of HealthLinks is they needed an overseeing organization like a parent organization to allow them to have some funds that they could reimburse the volunteers for just the minimal expenses that they have to incur, but their time is volunteer.
Right.
And
This says very clearly, as most all of these organizations are, that this particular volunteer guardian task force, it does recruit and train and evaluate and monitor the volunteers. And as this is true of many of your organizations, like Bridges and whatnot, that there is a little bit of training that's involved so you know what you're doing.
right. And it's different for each of the different organizations.
Oh, of course, it
what
would
they're
have
going
to be,
doing.
because
Right.
each one is so different
That's right.
and needed. What have you found most gratifying about your work with Bridges?
Well, it's so nice to see the relief in the family's voice if I don't get to meet them, or in their face, to know that if they can't be there, that there's someone who's willing to be there for their family member. And it just puts their mind, especially if they live out of state, or especially if they aren't able to be close by. They're just such, there's just such relief, in their, I mean, I just had a woman the other day when I called, and she was like, oh, thank you.
Yes,
I mean,
yes, yeah.
And that's really nice.
It's
to
a
feel
real
that
burden
you're
lifted off,
really
and it's not
helping
even for
someone.
people who are out of state or away, but maybe have a full-time job or other commitments,
That's right.
and
That's
where
right.
they just can't be there,
Can't be there.
cannot be there.
And working with the volunteers there, they're just wonderful people. I mean, they're just terrific, and it continually amazes me. The giving that's there, and the caring, and some of them get really involved with the people that they work with. And I try when I can to have, if I have a repeat call, to send the same person, so that relationships really have developed as a result of this. And a few have been renewed. We've had a couple of situations where it turns out they knew the person years ago. We had
Oh,
one-
really?
Yeah.
Well, that happens in Vermont.
It
Vermont is a
does.
small town.
That's right. And we had, especially some of the nursing home residents that we've helped. We have one lady. She discovered this. One lady was her second grade teacher.
See?
I mean, and
But
one she was
that's
involved
sort of
with.
like the Lord working, or a deity or something. The universe is working to bring people back together again. It's a win-win situation, Betty, for everybody.
It is. And one thing that my goal again for the Bridges volunteers is to have as many in different communities as possible. And again, when I've had that in different communities, like in the Brandon area, for instance, you have a volunteer, and often you'll find they know the person that I'm, if it's a Brandon resident that needs help and it's a Brandon volunteer, then they may know them. And that's, people are on both ends are more comfortable, if you can hook those two people up together. I will say, for anybody out there who's watching who lives in the Castleton, Fairhaven area, or even in the Poultney area, I do get calls from that area, and I don't currently have any volunteers over there. So we really are.
So we're looking for
always in
volunteers,
need.
especially for Castleton, Fairhaven, Orwell,
And
Poultney,
Poultney,
all that whole little.
the west
area.
and south of Rutland. We have them, and don't get me wrong, I need volunteers anywhere.
Well,
But those are
there again,
particular
you could
areas
live in
where-
Rutland if you were willing to travel to
That's
those
right,
areas,
that's
but
right.
there
And
is a
some
need in those
people-
areas.
and especially when it comes into the winter time and so on, it's nice to keep people as local as possible, if that's possible. But certainly, if you're in Rutland and you don't mind traveling out there, I need volunteers no matter where, because again, the bigger the pool, the more
The more
likely
you're
you'll
able
be
to
able
do.
to match,
Well, that's right.
every possible request that comes, and I don't have to overburden any one person, because most of these people have very active lives.
I have two questions. Volunteers use their own cars.
Yes.
Is it a requirement?
Not a requirement that they drive.
But it's very good if they can.
Well, it helps, but what I've had several volunteers who they lived in town and they would take the bus. They would do more of the nursing home because they could take the bus to the nursing home and ride with the resident and ride back, and so they didn't need their own car. I have a couple of husband-wife teams where the wife didn't drive, but the husband does the driving, and the wife sort of does more of one team would do it totally together. And so that's encouraged. If you have a friend and you want to do this as a two-person team, that gives support for the volunteer as well as for the person. If you live even in an outer lying town, you wouldn't be able to come in and transport the person home, but that doesn't mean that you couldn't get to their house to provide, again, that companionship.
The service,
We have such a variety of calls. It really runs the gamut that I would never want to say don't call me. You know, if you're interested in the program, interested in volunteering or learning more about it, you know, it may limit you in some situations, but I would never say don't call, because we have so many.
It's such a need. It's a need.
It is
a need, and it needs to be filled, and it's only going to continue to grow. The need is going to continue to grow.
For sure.
The other. Well, now I haven't. It's the third question, but the other question I have is, do you match people up, like if there's the male volunteer goes to a male patient, or female to a female patient primarily?
Primarily. Unfortunately, I don't have very limited male volunteers at the moment. And occasionally, if it's a female is okay going with a male. If it's an older gentleman, and it's certainly not, I would never with a staying overnight situation. But if it's just to go into the home and make sure he had a meal or companionship, I had one woman who went and played cribbage with a gentleman, like to read to him, those kinds of things. So depending on the situation and what the volunteer is comfortable with. But when I can, I like to match male to male and female to female.
And how do you handle a situation like AIDS, where it's a infectious disease? Do you handle that?
We haven't.
But you may.
That,
I mean, we're coming into that in the millennium. And
it's actually it is a little difficult because the confidentiality is certainly a big issue as to what that person was in the hospital for. We do, when we do our training, we have a session in universal precautions, infection control. We provide gloves for people if they're going to be going in home, just in the event that something happens. And so if you operate under universal precautions, then you assume everyone is infected, and no matter what the situation with blood and body fluids, you would not touch them. So that is a tricky situation, and we haven't actually run into that, but
you may.
We may, and I think that we'd have to just treat all people the same and reinforce to assume that anybody might be infected with some kind of transmittable disease.
You would have to, right, of course, tuberculosis or whatever. But right. you would have an obligation to inform a volunteer that this person has a infectious disease, and it's certainly their choice as to whether they wanted to help that person. I would assume, am I right?
Yeah, well,
they'd have to be informed.
I'll have to. He caught me. I'll have to check, because the confidentiality, especially with AIDS and with HIV and AIDS, there's. And I would need to, if we have a situation like that, I would need to double check on just what you can and can't, because there are a little bit more specific procedures as to revealing the nature of that kind of a disease. So if we had that situation come up, I would need to
investigate.
I would.
That's right.
And, I mean, it's, again, which is why we need to reinforce the universal precautions, because it's possible I wouldn't know. I mean, it's possible they wouldn't know, I mean, they're, so
in Vermont, maybe that would be something where Vermont Cares or a different type of organization would come in that was specifically geared for that situation.
But again, it's this case of where, again, people can be HIV positive and not know it yet because of the length of time. So we have to just, and that's why we don't provide a lot of the hands-on care, because so we don't have to, but that's why we provide the gloves in case you're in a situation unexpectedly, then you need to protect yourself with the assumption that anybody could be infected with anything. So
isn't it sad that we live in that society?
Well, it is.
But it's a reality.
That is a reality.
And we have to live with it and make adjustments. Yeah. I'm Pati Papineau. I'm talking with Betty Spooner, in case you just tuned in. And she is involved with a couple of programs under the HealthLinks Incorporated. It is really an umbrella organization. I'm going to say this over again because it's amazing to me that in just a couple of years, over 50 plus agencies have been brought together to help people in the community, whether it's senior citizens, informing them on law enforcement, helping people with bereavement, helping people when they come home from the hospital, and doing little things, not a home health aid, but just giving them a transportation or helping them unpack or getting them medication. There's an info line involved where you can call and get information on all of these agencies. We're only touching the tip of the iceberg. Then there's a clinic in Park Street in Rutland in the Vermont Achievement Center, where you can go if you have no insurance whatsoever. It meets Tuesday evenings.
Correct.
Is that right? But you need an appointment, so you need to call that and get an appointment and set it up ahead of time. It's not a walk-in clinic, and it is limited to one night a week, staffed again by medical personnel, trained medical personnel. There's a volunteer guardian task force that works with local probate courts for people with needs, and these volunteers are assigned by the court to help these individuals. We have the Long-Term Care Coalition for people who need residential care. InterAge, which is terrific, which is a new, fairly new agency in Rutland, located on Court Street near the library for daycare for elderly senior citizens. Not baby care, but daycare for senior citizens, which runs basically on the same idea.
It's
the
also
PALS,
for disabled, elderly
and disabled. Thank you very
that's
much.
cool. Yeah.
Family Ties to helping people liaison with the state agencies, that sort of thing. What else? The Safe Use of Medication Task Force. We didn't talk about that one. I guess that's pretty specific, but I think that that's really, really important because you have so many elderly senior citizens, and even if you're not elderly, but when you come home from the hospital and you've got 6 or 10 prescriptions in front of you, and the day and the time has to be, and whether you take it with milk or with food or water, and people can get that confused, and it can be, I would think, lethal and toxic.
Yeah, this group has met in the past. Some pharmacists near have volunteered their time to have. They've had what they've called brown bag sessions. And you literally tell people, bring in a paper bag with all of your medications, and they'll just sort of help them sort it out.
Right.
Provide medication use boxes, the ones that have days
Little
of the
days
week.
and times, right? I've seen those.
Yeah.
So it really promotes the safe use of medications
It does.
for
It just
everyone,
provides
and it can
information.
be very confusing, and to know, what symptoms are and what you shouldn't take, and all of that. I mean, even for my own self, I mean, I've had asthma medications. You need to know, and it is confusing.
Sure.
And I'm not, I haven't, I'm not elderly yet, but I think that's a wonderful need, and it is, pharmacists are involved in that, and they are certainly the best people to know. All of these umbrella organizations and these agencies are headed up by people like Betty Spooner, who are really trained and experts in their field, who know what they're doing, and the volunteers that are involved and staffed by volunteers, they have all had some kind of specific training in each one of these projects so that they are also informed and knowledgeable on what their duties are as a volunteer. And another question is, we talked about the Bridges volunteers that you're involved with, and that they are limited. I mean, they are not limited, but they can say how many days or hours a week. Are basically all of the agency volunteers like that, or do the others have certain, what is the word I'm looking for? The certain, not a tour, but a certain amount of time, like, you volunteer from 1 to 3 or 11 to 2 or something.
Well,
specific times, or it varies, depends from agency to agency.
Bridges, I think, is the primary one in that has a larger pool of volunteers. Now, the clinic, if you want to volunteer for the clinic, she does her schedule out as weeks
Right.
ahead of time.
Of
to
course,
try to,
sure.
So in that case, you are signing up for a specific time, but it's kind of a one. I mean, it's not like every week you're required to do that. Required. Nobody's required if you're a volunteer, but
Asked. You're asked.
That's right. Family Ties, she has kind of got several ongoing family members who participate on a regular basis with her. And I don't know, I think theirs is more scheduled, but in all cases, we all recognize people are volunteers, and so we really appreciate that, and it's not the same expectation that you have to do anything. You do, your time is just very much appreciated. So
I think
there's
that's
flexibility in all of the cases, but probably Bridges is the only one that is totally an on-call almost kind of thing, except that when you don't have a beeper.
Right,
So,
right.
But
I think this is a real important time. I would like to thank everybody who's volunteered in one or maybe even more than one of these 50-plus agencies to make HealthLinks a success. It is a success. It is growing and mushrooming with a great deal of respect in the community, which it well deserves. But in any organization, no matter how many people you have as paid staff, if you don't have the volunteers to go out in the community and to do a lot of this work, you're not going to be a success. And this is certainly a time where I, as Pati Papineau and a resident of Rutland and Rutland County in Vermont, give a heartfelt thanks to all of you who've helped make this a successful program. And certainly Dr. Gorman for starting it up and conceiving this, and the board of directors, because it is just phenomenal what has been done, and more importantly, what can be done. Now, we're going to give you the 800 number. Again, it's
1-888-718-8855.
And the Rutland phone number is
747-9961.
Now, if you call, there are some terrific brochures that are available that I'm sure Betty Spooner here, who is involved with HealthLinks and specifically Bridges and Infoline, would be happy to send them out to you to give a little more explaining of what is done. The Infoline, please remember, the Infoline is just beginning. It's starting, so it is not 24-hour a day. It's not 7 days a week. Call, leave a message, and they'll get back to you if you don't get through the first time, and you just might get through the first time. We want to talk again about Bridges. It's volunteers who provide short-term care, and they're non-medical assistants. Remember, these are not nurses who are volunteering their time. These are not home health aides who are going to come in and clean and bathe a patient. These are people who are going to do light, little, friendly tasks of companionship to help people in many, many ways. If you have a need, if you have a question, if you have a concern, call Betty Spooner.
We didn't give that number.
And we want to give that number.
That's my number. Because Bridges is based at the hospital, that's my office at the hospital.
And yes.
And that number
is
747-3710.
Now that's the phone number I've used for the last umpteen months.
Yes.
So it works, it exists, it's great. That's why Betty is here. This is a great, all of these pamphlets, but especially Bridges, answers your questions and what types of services are available, what dates and times can be done, whether an overnight stay is required or not required. Does a patient smoke? Does a patient have pets? These are all factors that, you call. There's no such thing as a stupid question, as far as I'm concerned. Never, never, never. And knowledge is power. And the way that you can utilize these wonderful agencies and projects and offices is to call and get the information. And if you find that it might be useful to you, fine and wonderful. If you don't, what have you lost? Nothing. 5 minutes, 2 minutes of your time. But it can certainly be a big difference in your life or in the life of someone that you know and love. Closing remarks, Betty Spooner.
Thank you very much for having me.
I didn't mean for that.
Oh!
I just thought you might want closing remarks. Thank you. But I mean closing remarks if you wanted to say something to the viewers about HealthLinks and Bridges.
Well, we're very excited about both of the programs. Again, I can speak best to the ones that I'm involved with.
Of course.
And I always need more volunteers. I think that's probably the message we try to be, again, really flexible with our volunteers and really show them how much we appreciate them. And it can be a real rewarding experience for them. And we have fun when we get together. And I really, and as far as the info line, I look forward to people calling and that becoming a really useful service for the community.
Very important. All of it is really, really important because you're out there, you exist. and the other service that's involved that is free of charge is to call people like at the Rutland County Sheriff's Department, Lieutenant Underwood, or Dr. Gorman at his office, or Betty Spooner at her office at Rutland Hospital, the clinic at the Vermont Achievement Center, and talk to these people and ask them if they will come and talk to your civic organization or your group, be it 5 people or 50 people, and explain how they exist, why they exist, and the wonderful good they're doing in our communities. And I'm going to be signing off now because we're running out of time. I thank you for your time and your effort.
Thank you very much.
I'm Pati Papineau. This is a beginning and an ongoing series that I will be having over the next many, many months on we in the community and how we can improve our community and get back to community values. That's patriotism and leadership and caring about our fellow Vermonters and caring about the fellow people in our own communities, in our own backyards who may or may not be in situations of need, but it's getting back to what I think our country was built on. And starting with that, with we in the community and making our communities safer and better places to live. And I can't think of a better way to start this program than by having Betty Spooner under HealthLinks. Please stay tuned for this as we continue on. We're going to continue on in law enforcement. We're going to continue on safe communities. We're going to continue on into legal aspects. We're going to talk about sex offenders. We're going to talk about leadership. There's just a whole year ahead plan that's going to be very interesting, I hope, to all of you. Until then, I'm Pati Papineau. Thank you for bringing me into your living room, and be happy and drive safely. Hi, I'm Pati Papineau, and welcome to my show. To many of you who have been my faithful viewers for many years, know that I have frequently do shows on alternative medicine and holistic medicine. And on today's show, I'm not doing quite that. I'm doing something that has had a popular resurgence over really the last 2 or 3, 4 years in this country, and something that was done since time began, and that's midwives. And we have a wonderful, delightful guest to talk to you about midwifery, and her name is Roberta Devers Scott from Rutland, and she is a certified midwife. She has midwife on her license plate, so if you ever see her in a hurry going down the street, you can know there's a wonderful new life coming into this world, and she'll be helping in that endeavor. So I have lots of questions for her, as I'm sure you do at home, because we all know what midwives are, and we know and we think we know, but we want to talk about it a little more in detail. And so please meet Roberta. How are you?
Fine, thank you.
No births tonight.
Last night.
But we're crossing our fingers for this taping that we're going to make this hour
that
through.
We're going to get through the whole thing.
Get it through. How long have you been a midwife?
14 years.
14 years. Certified midwife means you have a certification, a licensing to do that.
Actually, I'm a certified professional midwife, and that credential is now a national credential, making its way state by state through legislative efforts. It's the basis of certification and or licensure in 17 states now, and it was really created as a way to recognize what were previously referred to as lay midwives.
Mm-hmm. So it's important to be. Clearly, Vermont is a state, one of the 17 that requires certification.
Actually, Vermont is an illegal state. We practice without any legislation here whatsoever, and we're working very hard. The Vermont Midwives Alliance is working very hard now to use the certified professional midwife credential as a basis for certification, and those efforts are underway now.
I think that's very important, because I don't care whether you're getting your hair done, or you're having a baby, or your child is being taught, swimming. You must have an instructor and someone that knows what they're doing and is certified.
It's very important.
It makes a difference between a professional and non-professional.
And it's in place. We don't have to reinvent the wheel. It exists, and we're going to ask Vermont to recognize it.
Well, I think that's wonderful. I hope all Vermont is listening, because certainly if you have a midwife, you want her to be certified and professional in that endeavor. And something that I found out, lots of times people, when you have a title, they already assume that you have the certification, and that doesn't always exist. The two don't always coincide. As you say, it does depend upon each individual state and the legislation in that state. So really, this is a wonderful thing, and we really hope that we can get midwives professionally certified here in Vermont. I think that's important for everybody, because people are going to continue to have babies. That's a fact of life.
Yeah.
No pun intended. I'm sure that a lot of women think, oh, I would love to have a baby at home. There's wonderful advantages, but suppose something happened. There's a little bit of, So tell me, let's talk about, first of all the advantages there are to having a midwife at home.
Oh, they would be too numerous to count, Patty, but I think if I had to sum it up, we know very clearly that women progress best in labor and in birth when they're in places that offer privacy and comfort and familiarity and respect. And because of certain constraints, sometimes hospitals aren't always those places. They try their best, and I know that they're very well intended, but there are so many protocols, there are so many medical legal issues, there are so many economic issues that the hospital has to deal with, that at times they are unable to give women the same kind of attentiveness and the same kind of continuity of care and the same kind of respect that midwives are often able to afford them at home.
I would think that would certainly be one of the major advantages of just being in your own home, in your own environment, and privacy. Something that's just never ceases to amaze me, that you can sit in a room full of women of all different economic levels, all different professional levels and non-professional levels, all different age levels, from teens to 20s to elderly senior citizens, all ethnic and cultural backgrounds, but the one tie is that they all can talk about their experience of childbirth.
Yes.
And it's an immediate icebreaker, it's an immediate camaraderie that all women have.
Yes. It was found that very elderly women in nursing homes, when they couldn't recall very much else about their lives, could recall the
birth
story,
of their children.
the
Yes.
stories of the births
Right.
of their children.
Right. Certainly, I mean, women have been having babies since time began, not even at home in wonderful, clean, lovely beds and environments, but, you know, read once where Indian women, when the tribes were moving along, if they felt the contractions coming, they'd go off in the bushes and deliver that baby and then rejoin the tribe later. So sometimes women worry about, I think, that being that sterile atmosphere. Want to address that?
Well, I think that a good way to address that would be to talk about how was it that women stopped birthing at home, in their own homes, and moved into birthing in hospitals. And there's a misperception that the perinatal mortality morbidity rates dropped dramatically because of the advent of hospital birth. And really, the perinatal mortality morbidity rates dropped as a correlation to potable water and improved nutrition and improved sanitation, not because of the advent of medicine. And so better outcomes in birth, both for mothers and for babies, are linked now, very, very well linked to people birthing in hospitals, when that really isn't the truth of what made birth safer for mothers and for babies.
Oh, I think that's a good way to answer it. And it brings up a very good point that it can certainly be done at home. My father was born at home. Were your parents born at home?
Both my father and mother were born at home. My son was born at home. Actually, my son.
My mother was born at home too, come to think of it.
Yeah, my son and my father share the same birth date, but 60 years apart, both born at home. But I wanted to make another point about what I was saying about birth being, brought into the hospital. I think that what we need to understand about birth is inherently safe, that birth is not an accident waiting to happen, that birth is not impending doom, that actually birth is very, very safe.
Yes, I think that's a good way to put it. Let's just take a scenario. At what point would you send a woman to the hospital? Some women is watching and say, well, I really think that this would be a wonderful way, and I would have my parents there, or my husband, or the father of the child, or my other children. It might be a wonderful thing, but what if something happened?
Well, I think we should talk about the fact that midwives are trained to handle emergency situations and trained to handle them nicely at home. There's also a misperception that everything needed to handle emergencies is in a particular institution. Everything that someone needs to handle emergencies can be put in a birth bag and brought to someone's home versus that woman going into the institution. Appropriate resuscitative equipment for babies, anti-hemorrhagic drugs for mothers, those are the things that make birth safer if there are complications.
And there can always be a complication. We can't deny that.
There can always be a complication. And certainly you want to be very astute and very aware of what is happening in that birth process. Of course we monitor fetal heart tones. Of course we watch that labor very diligently, and we listen to that baby, and we take blood pressures. Of course all of those things are done. And there's also a misperception that emergencies occur quickly. Actually, that is not the case.
No, that's not
that in 90%, greater than 90% of the cases, what someone would consider an emergency is really quite a benign situation, like heart tones are not sounding very good, and we know that we really need to move into a higher care center, and we need to come out of the home and be in the hospital. But we always have time to do that, almost every single time.
Oh, yes, because a labor is hours. I mean, no matter how you cut it, it's either a few hours or a long, long time. But you're looking at something as a very good point, that if there's going to be a problem, it starts hours before.
That's right.
Hours. And
that's right.
A car accident or something, you're looking at seconds and minutes of saving a life.
That's right. The body normally shows signs. Something isn't quite right. And you know that if you were to keep that woman home any longer, what was not quite right would become certainly not right in a little bit. And so if you're a good midwife, you take somebody to the hospital far before something becomes an emergency that's out of control. This isn't the way that things happen. Certainly occasionally there's an emergency situation wherein that particular woman would have been better off had she begun in the hospital than had she begun at home. But in greater than 90% of the cases, you have ample time to transport someone. And your transport situation also is in order. Women have parallel care with obstetricians, women planning home births, where the obstetrician knows their history, they visited them a few times, they know what hospital they would travel to, all of their emergency numbers are posted by the phone, and all of that is in place. I should also say that our transport rate is under 5%. So that means that 95% of women who intend to have a home birth actually stay there and birth at home. It's a very low transport rate.
It's very low, and I think that's one of the most important things that we can get across in this show, is that it is very, very safe.
It's very safe. Actually, studies have shown that home births are as safe or safer with a skilled, well-trained midwife than hospital birth, and there's never been a study to show the opposite.
Well, it's also interesting that every once in a while you read about an emergency birth done at home by a state police or a city police, a law enforcement official, or something along that, or a dad, you know, en route to the hospital. Perfectly safe. Babies born in cars and back seats and all kinds of things. Perfectly safe.
Yes, it's an inherently safe
Not
process.
the most ideal environment. No. You know, it's not what you would really hope and want and pray for, but it does happen, and the baby is fine.
Yes.
You know, is it really true what they show in movies that you have to have a hot pan of water?
Well, the baby would still come out if you didn't have a hot pan
Yeah,
of
that's
water.
true.
Yes,
Oh, yes,
but
Patty.
it is true that one of the things that we offer at home is a constant sort of toolbox of comfort measures. And one of the comfort measures is, believe it or not, a crock pot with some ordinary diapers or washcloths in there to keep them warm. And the difference that makes, offering hot compresses on a woman's belly or a woman's back, can be tremendous. You know, just the comfort measures.
This is a wonderful idea. You just brought up something so important. Gee, if a woman has menstrual cramps, or you have back problems, or any kind of problems where you need to put warm cloths in a crock pot.
Right.
Oh, how ingenious.
But for the entire labor.
But for a labor, absolutely. But this is a great thing.
They're always there offering her compresses or counter pressure on her back if her back is bothering her, or a cool cloth for her head for hours and hours and hours and hours, as long as it takes throughout that labor. That's what midwives offer. And I believe that there's no other way than that, that women should be attended to. We are the drugs. We are the painkillers.
Well, when I was pregnant, I made a concentrated effort to get a woman doctor, because I feel that a woman gynecologist, and I have now Dr. Kaylin Brown, who's our gynecologist, both my daughters and mine, from Burlington, and has done this show many times on breast cancer and AIDS and things like that. But it's very simple. A woman who's been through it has more understanding, I believe, and compassion.
Some male physicians have argued on this point.
Oh, I'm sure they have. There's no question in my mind that they haven't argued it, but that's my opinion.
I would say that empathy, we often talk to midwives who were midwives before they had their own children, and we ask them how it affected their midwifery. And, you know, it's hands down. Of course it affects the way that you attend to another woman. There is nothing like empathy. There is nothing like having that experience yourself.
And smaller hands.
Well,
that's true.
Perhaps.
And somebody's saying, what did she mean by that? Think about it. At what point do you come in on this labor?
Whenever a woman needs us.
Oh, Oh, great.
which is the other point that I think is important, that particularly with first-time mothers, we try not to go to the home too early because, a watched pot never boils, and we don't want them to feel like somebody is there really watching them and observing them unnecessarily. On the other hand, they know that even though sort of the standard medical definition of labor is not what's happening to them, they're not 4 centimeters with strong regular contractions, if they say, even though I'm 2 centimeters, I need you here, then that's where we are, because she's told you she needs you.
So nice. Can a woman tell how many centimeters she is? Can she sense it or feel it at all? Not unless she's really.
I think she probably would be able to if culturally we were more in tune with our bodies and we weren't looking outside of our body for information.
That's interesting.
I can tell. I can almost always tell by doing a vaginal exam, and we do very few vaginal exams, and I believe women could tell too. But culturally, we're really so hooked into having other people give us information about our own bodies that we begin to forget that we're the best judge of our own bodies.
Absolutely. You, and we should tell everybody, you are doing this show. We're doing it on Midwives. You are certified. You are here, and if somebody should be in labor now, not only does Roberta have a cell phone, she has a beeper, and she has a fill-in, a replacement, a substitute, you have someone that you work with. No, I thought you had a replacement.
There is no replacement for me, because when you contract with me, you always get me.
Oh, well, let's hope. Don't get to go into labor.
Yeah, I've told them. Someone is
told everybody. I'm doing the TV show with Patty.
I have. Someone is due. We had a birth last night, a very beautiful birth, and someone is due Saturday on my birthday. But we never send someone else in our place. We have other midwives that we work with, and oftentimes 2 midwives are present at your birth.
Really?
But I'm on call, 24 hours a day, 7 days a week, 365 days a year. And when I see that there are no births in a particular several-week period and I can get away for a couple days, that's great. But oftentimes, it's months and months and months.
I would think so. I mean, it's constant.
We feel very committed to not having midwives in this practice take call, because then you still get into the situation of, I think, removing yourself just a little bit from that family, because you don't know if you're going to be the one at their birth. We really honor that they've chosen us, and we really develop very intimate friendships and relationships. And when it comes time for them to be due, I still, after 14 years, would rather be there than just about anywhere else, almost every time.
It's certainly a very wonderful experience to bring a life into the world and to see firsthand the father and the relatives and the kids and the family, whatever members are there, instantaneous joy on their faces.
Yeah, it's never gotten old in 14 years. Sometimes in the middle of the night, when I'm driving and it's a blizzard and it's 2 in the morning, I think, oh, or I'm at a 2-day labor, I think, oh dear. But you're right, it always comes back around, Patty. Certainly last night when the mother had birthed the head of her baby and the baby was still inside, and she was able to look down and see the whole head and the face with the body still inside, and the look on her face, it never, ever gets old. It's a very, very beautiful thing. Midwives will tell you that it's a deep calling. Truly it is.
I believe it to be true. And I can certainly see it on your face, the peace and love and warmth in your personality. And I've just met you. I mean, we're not long-lost friends here.
No, we're not long. We could become long-lost friends.
I like that.
But it definitely is. It's a deep calling. I'm very lucky in my life. I mean, I'm very, very lucky to be a midwife.
It's very fortunate in life for each one of us, male or female, to do something in our lives that we truly love in our heart, because then it's not a job.
No, it never is a job.
It's not a job, and it's not, it's a joy every day to wake up, and it's a joy to do what you do.
Absolutely. There isn't a day. I think that the politics behind it are very, very difficult, but the families and the births sustain you through the politics of midwifery.
Well, I think probably when you talk about politics, you're talking about people who still have a little bit of apprehension and aren't quite sure what's involved. And the thing that I like about it, I mean, I love several things about midwifery, although my daughter was born in a very small hospital here in Vermont. And I purposely sought that out. And I lived in another state, and I came back to have my daughter here because I wanted a very small, homey, comfortable, loving, caring atmosphere that I felt really and truly would be in a very small Vermont hospital, which it was. And by one doctor, a female doctor, as I said, but also a doctor, she's the only one in her practice. So I knew that she would be there at my birth. And I hear so many stories of, and there's nothing wrong with it because every woman is different. But I felt that that's what I needed for Pati Papineau. But so many women go to the doctors and they go to gynecologists and they have, you know, umpteen, a half a dozen or a handful of people involved and doctors, and you never know who's going to be on call and when so you don't know who's going to be delivering your baby. And I think that can be sometimes a trial and tribulation, a little uneasiness, because I've heard women say that. Gee, I hope I go into labor on the 3rd week of the month because so-and-so doctor will be on call.
Well,
you know, they go through that, and I'm sure you heard that too.
Yes, and I think that I want to say a couple things about that. I think that first of all, when I say home birth, that oftentimes what sort of the atmosphere that we create at a home birth, I've seen that be created in the hospital sometimes. I mean, it's not.
Oh, we're not saying it happens all the time, but it's that element.
It can happen.
There.
It can
happen.
happen.
It
can
does.
happen in birthing centers. It can happen in hospitals. It's more unlikely in the hospital situation just because of the institutionalization of the whole process there. But it can happen. And the second point about that, I think, when you have to accept whomever is on call, part of the problem with that is that particular physician or even nurse midwife, or if you're in a practice that even home birth midwives take call, those particular people, because of rotating you through, have not been able to get to know you as intimately
as your own personality and needs.
And you must, as a midwife, understand that woman's deepest fears, her needs, whether she was a victim perhaps of sexual abuse,
anything,
what her relationship is with her partner. So many things can impede labor and can help labor to progress. And if you don't know her intimately, when she shuts her labor down, you reach for Pitocin or a drug to help her because you don't know what to say to her. If you knew her intimately, you could speak to her simply and get the labor going again.
Really?
Oh, yes.
It's amazing.
Absolutely.
It's absolutely amazing that you say that, because I've always believed that what is in our environment affects our bodies. And I'm not talking about pollution, but I'm talking emotions and stress and what we go through. And I've always believed that the babies can pick up on that in the womb.
Well, they've also done studies, Patty, that say that nocturnal animals give birth most readily in the day, and animals who are, and why is that? For the sake of privacy.
Peace.
Yes.
Peace.
Yeah.
I'll just interject a little funny story that sort of proves that, is that I had read that the baby can hear sounds and all of that when they're in the womb. So I had bought this little wind-up dog toy. I used to wind it up and it used to play, and I used to put it on my belly all during my pregnancy. And I can tell you that my mother and everybody laughed at me. That's the most stupid thing. That's ridiculous. Well, until my baby Cammie came home and she started crying, I took that little toy and I wound it up and I put it with her in the crib, and she went sound asleep. And boy, nobody ever laughed again. So that's to any little tip to any mother out there.
We're finding out a lot of things about
it's amazing.
Babies in utero and bonding experiences that it took the research of Kennel and Klaus to really establish that those moments after birth, the bonding moments, are so critical to a mother-infant relationship. And we know this now. You know, we always knew this in our hearts as women, but it took all of this very scholarly research to
I don't know if all women, I hope that we as women would know that, but I think maybe some women aren't really so aware of that. But I always felt that it was very important that a baby be born in a peaceful atmosphere.
Absolutely.
And you know, do you remember that old, was it a concept of Laboyer method, where babies, that they were born, no matter if it was daytime or night, with the shades drawn and the room was kept dark.
Right.
And the baby was taken out very calmly and placed in warm water immediately. And I'm just saying that. I know you probably know that. But that was kind of the concept of that. And that the baby didn't come out and be whacked on the fanny and go through all this trauma and all this stuff. And I felt that was really better for the baby, for bonding and emotional, and that's what I requested at this hospital, and they were very happy to accommodate it. And only 2 people were there. I don't know if, unless it's really a serious situation, I don't know if you need all this hustle and bustle and activity going on and these machines going on. I don't know what, if that is,
If they're
it's right for some people, but I don't know how,
if they're
for the kid.
anticipating a high-risk situation.
Oh, that's different.
Absolutely.
Absolutely, you have to have that.
Absolutely. There's a pediatric
right.
team that comes in. This
Right.
absolutely.
And
this
we need
changes
that.
everything.
We need that today, and we're glad that we have that.
Oh, the advent of the
Yes.
cesarean section
Absolutely.
has saved the lives of women.
And neonatal departments and so on and so forth.
Absolutely. I mean, we've made such progress. The only thing is that sometimes with the advent of technology comes an overuse and an abuse of that technology, and that's what we have to be careful of now, because the cesarean rate is 3 times what the World Health Organization says it should be. 1 out of 4 women have a cesarean
Is that
section.
worldwide, Roberta, or in the United States?
Oh, no, not worldwide, in the United States.
In the United States, doesn't surprise
In the
me.
United
I
States.
think, remember at one time the statistics were like that for hysterectomies too.
Well, they're getting up there again
Yeah.
for hysterectomies.
Are they again?
Yes, but we have to. The American College of OBGYNs has been told time and time again to lower their cesarean rates. We have to stop doing major surgery on a woman who really doesn't need major surgery. That's not okay.
Yes, it certainly, if it's done for a convenience, for the doctor's convenience or the mother's convenience of not having to go through labor. And I've known women who have requested cesarean sections just so they wouldn't have to have a long labor.
Yes, and I think
Put yourself through all that.
well, also
Is it good for the baby?
it's sometimes simpler to give the woman the pain medication she's requesting rather than to allow her to have the disheartening moments that come with labor. Labor is wrought with disheartening moments. It's very challenging. It's very
Oh,
difficult.
yes, it is. Yes, it is. Yes, it is.
That is an understatement.
Yes, it is.
Yes, it is.
I was induced for over 40 hours.
yeah.
Induced.
Yeah, it's not. I mean, it's a very
I
challenging.
just get this baby out.
It's very challenging.
Oh yes, that's challenging. Okay.
That's
I just remember
very
the lovely nurse kept saying to me, "Oh, but dear, you'll forget all about this." Well, now my daughter's 16. I still have not forgotten about that.
right.
Pain.
I mean, it's challenging, but I think when those disheartening moments come, that's when the midwife whispers, "But you are doing this. You keep progressing.
Right,
You
right.
are strong."
Right.
It's not.
And you'll never repeat that moment again.
Yes, that moment is gone.
That forever.
Every contraction takes you closer to holding your baby, to having your baby.
Right.
Instead of just saying, "Yes, I'm happy to go and get your Stadol."
What's that?
The drugs
pain?
that they
Oh,
use,
yes,
or your epidural. And
Yeah.
let's be very clear: these interventions, these drugs, these epidurals are not without risks, and we know that now. They're not without risks. One intervention normally leads to a cascade of interventions that interfere with the birth process and disallow it to take its own course and to work. So they're not the greatest. They are not. They have their own problems.
We are talking with Roberta Devers, Scott, little dash in there. She's from Rutland, Vermont. She's a certified midwife. When that's what we are talking about in this program, for anybody that might be tuning in. We're talking about the advantages of it, dispelling some of the fears that people might have or misconceptions, even though it's been done since time began. And also, we also want to say that we're not promoting hospitals and birthing centers, because they're wonderful. And they certainly are the great place to be to having a baby, and they certainly can help you. We're just saying that this is an alternative, and talking a little bit about it so that you understand more about it, and that it is really having a resurgence in popularity for very valuable and meritorious reasons. Right?
Very well said. Yes.
Oh, thank you.
Yes. Yeah.
I just love to talk. So you become on. So let's go back. You have a woman who is pregnant. She goes and she gets, hopefully, that she goes to a gynecologist, and she has a gynecologist, and she discusses it with her gynecologist, and then at some point she contacts you. If you are a woman who is pregnant or thinking of getting pregnant and going through the midwifery, how do you say that?
Yes, that was correct. Midwifery. It's midwife and midwifery.
Yeah, midwifery. That you should be called at 6 months, 5 months, 8 months.
We've taken women at all different stages,
Okay.
Patty, and that's because some people come to me before they get pregnant and say, I know I want to have a home birth.
Oh, okay.
What's it all about? What do I read? What do I do? How do I prepare? Some people go through the entire 38 weeks with an obstetrician and say, finally, there's this gnawing feeling that I have that this situation is not right for me. I would like to have a home birth. Now that's not ideal because I haven't gotten a
you
chance
don't
to
know
know
her.
her. I
Right.
can look at the medical records and see that her blood pressure was fine and she's had all of her lab tests, and that's not a problem. But I'd love to get to know her. And what she and I would do is we would see each other every couple of days. We might have lunch, we might have more prenatals, and just try to spend as much time as we can. So that's not ideal. But different women come to it at a different time.
At different times. So that any time is
It's variable.
okay.
Any time is okay.
Any time is
Yeah.
okay. And you have so that she would have a gynecologist, obstetrician on call in a local hospital.
Yes, who
And
she's
so
visited.
She and knows and has a rapport with or a connection
That's
with
right.
there.
That's right. And the obstetrician knows of me and knows of my practice normally, and I've normally send them letters and fax over the prenatal records, so we keep in touch during that woman's pregnancy. And if anything at all is out of the ordinary, we consult, of course. And of course, then that person is in place if an emergency does occur.
Have you ever delivered a baby in a hospital?
Yes.
You have. Okay. Other than your own.
Well, that
I
baby
didn't
was
mean to-
born at home.
That
but
baby was born at
yeah.
home. That was just a curious question.
Yes.
Yes. The other questions that I have is, how would a woman prepare, other than with meeting with you and talking to you and reading, the normal literature and books about having a baby? Is there anything specific she needs to do to prepare for her home birth?
Are you asking me in terms of supplies, or how does
Everything.
this whole thing work? They're given a welcome package at the beginning when they come into the practice, and the welcome package really explains to them what kinds of supplies they have to have on hand. We make one home visit during the course of the prenatals to be sure of directions to a family's
Right.
home and to be sure that they do have all of their supplies in place, and to just look over the house and sort of familiarize ourselves and maybe give them some helpful hints about where it might be best to deliver. Sometimes we suggest picking up a little bit, or
Yeah. Well, you have to.
just just
basics.
get
just
it all,
basic.
just the basics, get it all ready. Most of what they need is they're very, very simple household things.
Okay.
It's not anything out of the ordinary. And everything else the midwife brings. So
does.
we bring 2 tanks of in my particular case, I bring 2 tanks of oxygen, one for mothers, one for infants, appropriate resuscitative equipment, anti-hemorrhagic drugs, and everything, along with a variety of herbal remedies and homeopathic remedies that we do use on occasion.
Oh, I believe in that 100%. You are a little person. I mean, you're very slender and small, and the camera can't always pick that up, but you carried the 2 tanks in yourself of oxygen?
Sometimes the dads help me, but of course I do. And also, there's a number of women who I hold up during labor who are quite a bit bigger than me. So I'm little, but I'm strong.
I guess so. Yes, you'd have to be, right?
Yeah.
I just want to touch base on something that probably viewers are asking themselves. Does health insurance cover any of your services?
Yes.
Although we can't talk about prices.
Right. Yes. Yes, we've been getting third-party reimbursement quite readily. I think that insurance companies are recognizing that this is a very cost-effective way to serve women. And there has been, not in this state yet, however, that will be coming, a lot of legislative effort to make sure that third-party reimbursement occurs for certified professional midwives who are licensed in that particular state. We have to have that. We truly do. And on that note, midwives would love to take care of indigent women. They would love the women who have Medicaid. Those women really need midwifery services. They don't do well with a 6-minute visit with the obstetrician. They really need, most of them, more. And we'd be happy to give it to them.
Well, it's very difficult in this country for people who receive Medicaid to even find doctors that accept Medicaid.
Yes, in pregnancy sometimes it's better, but my issue with it is that The average OB visit in this country is about 6 minutes.
Is it?
The average visit with a nurse midwife in this country is about 20 minutes.
Mm-hmm.
The average visit with a certified professional midwife, a home birth midwife,
Mm-hmm.
is at least an hour. We never do prenatals that are shorter than an hour.
Mm-hmm.
I don't know how you would get to know that family without
Well, I
spending
don't
an
think
hour.
you really do. I don't think you're really looked on as a whole family. You're just looked on perhaps as a patient. I don't know. But, I mean, I can tell you from my own experience that I just had some deplorable experiences. And yet, there are many, many women who have wonderful experience. I would say a woman who has, the deplorable experiences I had was with one gynecologist, one obstetrician, and my whole pregnancy was very bad. I was very sick. But there are women who have 20-minute labors,
Yes.
as you know,
Yes,
or 40-minute labors.
Yes.
They should have lots of children. All the rest of us don't have.
With me.
Is that what you had?
No, I'm saying they should have lots of children with me.
Oh, that's what I mean. Yeah, lots of children with Roberta. But, you know, I mean, it would probably be a scenario where you might be lucky to get right there.
Yes.
Like maybe a birth that, you know, the baby was already starting to come out. Phew. I mean, that does happen. It happens in the hospitals. It would happen with you.
Just
Yes.
happened.
Just pull right, come right. There you are.
It just happened.
Yes, see?
It was amazing.
It's amazing.
It can be amazing. The
Mm-hmm.
long ones are amazing, and those that are under an hour are amazing. They're all
Mm-hmm.
amazing.
Now I have to ask, because we're into midwives and we're into fairy tales and wives' tales. Do you ever
Yeah.
do that little thing with on the top of the woman's belly?
Not me.
No? Have women ever done that?
Oh, they
that all
do.
the women do it?
A variety of things, Patty.
Right.
They
And
do.
and which one is most accurate? Is anything accurate?
No, nothing.
No. Well, there you go. See?
No.
They are fairy tales.
My home birth midwifery colleagues would not like to hear me say this, but probably for gender, the sonogram is.
Yes, that's the most
Sorry.
accurate scientific method, right?
Yeah.
Well, even a sonogram can be wrong. Rest assured.
Absolutely. A sonogram is often wrong.
It's so hard to see all those little blurbs and blobs.
Well, we need to understand that technology is not perfect.
That's right.
And there's an over-reliance on technology, and there's an over-reliance on believing that technology is perfect, and it is not.
And it's the answer to everything.
Life is not perfect.
Exactly right. That's exactly right. Right. And there's really no way of knowing with each individual woman how long or intense her labor is going to be. There's just no way to predict, is there?
There's no way. The beautiful mother who birthed with us last evening was a first-time mother and had an active phase of labor that was 1 hour, and pushed for 1 hour, and that's incredible for a first-time mother.
That's incredible for any time mother.
It's incredible. It's absolutely, and she
She's
just did.
very lucky.
Yes.
That would be really an ideal home birth, wouldn't it?
Well, I was glad for her that she didn't have to work as hard as some other women. But I think that what we try to impress upon a woman is that acceptance is such a huge part of this, and you must accept whatever your body gives you, because there's no other way.
Yeah, yes, what can you
really
do?
aren't going to change that, and
No.
if you can accept it, whatever you have to do to get that present is just what's going to have to be.
How many babies did you estimate that you have delivered in 14 years?
I'm on 520-something, so 520-something home births.
Let's talk a little bit about your background. Are you a Vermonter?
I'm not a Vermonter.
You're not a Vermonter, so all these 520 births weren't just in Vermont.
No, they were not in Vermont. They were in El Paso, Texas during my training.
Oh, Texas.
They were on the island of Jamaica. They were in upstate New York, where my practice was for 12 years, and now in Vermont for 2 years.
Wow, that's great. What is the one common denominator you see in all of midwifery?
I see that whether you call yourself a certified professional midwife or a certified nurse midwife, or now the new credential in New York State, certified midwife, it's very confusing to the public. There are many titles of different kinds of midwives. I just wrote an editorial and I spoke about this. I see that all those midwives have enormous respect for womanhood and a reverence for women's ability and a respect for choice and women's choices and for their own innate knowledge of their own bodies. And midwives know that to be crucial. That's across the board. That's the common denominator. And whether she is a Christian midwife or an Amish midwife, and I've known some, a partera in El Paso, Texas.
What's that?
That is the Spanish word for midwife.
Oh, a Spanish, okay.
They know that women's powers are immense, truly. And the other thing is they know birth is safe. They never look upon birth as impending doom.
Mm-hmm.
They're watchful of the process, but they know that birth is safe.
Mm-hmm. Mm-hmm.
That's what I would say.
Mm-hmm. It's very fascinating to hear your stories and all of these 520 births. Twins, triplets?
Twins. Yes, it's probably difficult politically to talk about that, but midwives, many midwives, believe that delivering breeches and twins is a lost art. Yes, it can be more complicated. Yes, there are more risk factors associated with them.
Of course.
But I really believe that they were medical legal reasons that forced many of those women to have cesareans as soon as there was a breech or as soon as there were twins. And there's an art to the delivery of twins or breeches.
Oh, I'm sure there is.
And I think that we need to revive it.
Absolutely. How many babies have you delivered in the last 2 years while you were here in Vermont?
Well, the practice, of course, being new, it began slowly. We were probably doing an average of 1 a month in the first year, and now we're doing an average of 2 to 3 a month. So I'm very pleased with how the practice is going. It's going very well.
It's wonderful. And the fee can be covered by insurance, and it would be for the whole kit and caboodle, I would
The
just
whole
say.
kit and caboodle, yes, for the prenatals, the labor, delivery, and the postpartums.
So it's a package.
Yes, it's a package.
It's a package for you for several weeks and several months, a package in every possible way.
Yes, we start at the beginning and we see them through to the 6-week postpartum period.
And who do you find usually is the partner in the delivery? Is it the husband, the father, a parent, child, sibling?
Who's the most support, Patty? You mean who's supportive? Normally, of course, it's the husband or partner. I served in the upstate New York area, a Mennonite and Amish population, and those fathers were not as apt to be with the women. Some would never come into the house. It depended on the order of Mennonite family that it was.
Interesting.
I also see, though, that a lot of women have what's called almost a lying in, an old-fashioned lying in, and that was
What is that?
when the other women in the community would come and serve the woman in labor. And as important as I think fathers are in labor, and they are very, very important, once again, there's an empathy factor wherein, and it's been since time immemorial, that women have come to women. Midwife means with woman.
Right.
So those births are also very sweet births when women come to other women. And sometimes we have, last night the woman who gave birth was attended by 2 women, a woman whose birth I had done last month and a woman whose birth I will do in December. So you see, it's a circle.
And they were friends, or they just came in to support?
I got them together.
Oh, you brought them together?
Yeah.
Isn't that lovely?
Yeah.
It's a whole concept, and all of what you do is beautiful, but the fact that the love and the joy that brings women together.
Yeah.
Not just the babies into the world, but these friends and women that otherwise may not have ever met and know each other.
It's community.
Absolutely.
It's community.
Love community.
It's community. I mean, there's a very, very sweet midwife that we have here in Vermont, in Barrie, who I honor very much. So if you're listening, Judy, Judy Luce. And Judy, I think is 54 and has been a midwife for greater than 20 years. And she is, her spirit of midwifery is really, really tied to the community. She really attends birthday parties of all of those children she's caught, and she's very tied into that, and she sees those families for years afterwards, and it's the way that it should be.
It's almost like in a church where a priest or a minister baptizes a baby and then does the first communion all the way up into the marriage.
Yes.
And in possibly a death. So, it's the whole evolution of life that's involved here. It's not just the delivering of a child
That's
for
right. That's
a
right.
few moments.
Yeah.
It's a lot involved.
It's community. You want to see these people. It's not a profession. It's not a business.
No, it's not a business.
I mean, there are business aspects of it, of course, and some of it has to be run as though it were a business. It has to be run professionally.
Oh, yes. So, yes, it's a business as far as that goes.
Right.
Of course.
But it's not a business. It's more than that.
Just curiosity, what is your feeling on artificial insemination?
Betty, you're going to pull out the hard questions now.
Well, just curious.
Well, I mean,
You don't have to answer.
no, I'll answer. I mean, I think that it's a complicated issue. Certainly, we've served lesbian women in our practice
Really?
who choose to artificially inseminate. I mean, we've had, you have to understand, first of all, that home birth crosses all cultural and religious
Oh,
boundaries.
I'm sure it does.
We
have to. All women have babies.
We have wonderful, wonderful, strong Christian families in our practice who I admire deeply, Mormon families, Baptist families, and lesbian women. And I've seen that those women can be, of course, wonderful and effective parents, and I honor them for that. And some of them would never have chosen pregnancy had it not been for artificial insemination. One of my dearest friends is a family practice doctor who's been artificially inseminated 3 times and has 3 beautiful children, one of which she had at home. And so for her, it was the right choice. I get a little concerned about all of this birthing technology now, this reproductive technology, and what the far-reaching implications
Absolutely.
of that are.
I think you said that beautifully. And I guess that the same would go for cloning.
Absolutely.
Oh,
It's very
my.
scary to me.
This to me is just opening up Pandora's box. I don't know what is wrong here with medical technology when we have diabetes and arthritis and
Yes.
epilepsy
Yes.
and all of these Crohn's disease, all of these terrible, debilitating diseases that are probably this far from having some kind of a cure, and then money, millions and billions of dollars putting into technology of cloning, and all of that money could just be dispersed and put into all of these other foundations, and certainly even cancer, and asthma. The list goes on and on. I don't understand this, what's wrong with people, and I understand what's wrong with more of us that don't speak up and say, we don't want our money going there.
Well, even the issue with all of the screenings for genetic problems, like the alpha-fetoprotein test and the chorionic villi sampling and amniocentesis, it really presupposes that a child who, if a couple found out their child had Down syndrome or some congenital problem, that in this society that child is not worth as much as a child who is essentially normal or healthy. And I just wonder what kind of a society we really are trying to build when we continue to talk about ideals and perfection. Nothing is perfect. So.
No, we never know what the Lord or whatever you believe in, Buddha or
Right, that's right.
is going to bring to all of us.
That's right. And on that note, I think I'd like to say too that some families have told me that they choose home birth because if their baby was not able to be resuscitated by what they perceive to be normal resuscitative measures, they would have no ability to say to the hospital personnel, that is enough. They have absolutely no ability to say that. And it was my own personal feeling and choice that if my infant couldn't be saved by normal resuscitative measures, those being the things that I thought were appropriate, I would have no ability to say that's enough. And I wanted to have that ability.
It's an interesting concept that I never really had thought about. And it's all about choices. Life is about choices. And that's what this show is about. It's the choice of choosing somebody such as Roberta to come into your home and to give you that experience if you feel it would be advantageous for you and for your family to have your baby at home. And we've dispelled, I think, a lot of the misconceptions that people generally have. A question that I would have is, you mentioned a few moments ago that we're the best places to have a baby. So sometimes it's not the bedroom or a bed? Or what do you mean by that? A certain room or a certain...
You know, Patty, it's been my experience in 14 years that people are drawn to different places. We've had people
Really?
have their babies outside in the birthing pool, the birthing tub, which is very, very
yes.
popular now. People rent them all the
Oh, yeah.
time.
Yeah.
There
I
was-
could, well, I only say that because I had that option too, and I thought, I don't think so.
But
But
see,
it's for
you,
it's
it was
choices.
not right.
That's
the
right.
choices. You know,
It's
I
a
said
choice.
the same thing when I saw that new physio ball.
Yeah.
You know, they have this new
Yes.
ball that
Yeah.
they,
Yeah.
you know, one father said it's like a hippity hop. You know,
Yeah.
remember those things?
Yes,
Different things work for different people, and so it's not my labor, and it's not my birth, and wherever she would like to be. You know, it's very difficult when a woman is squatting for you to lie on your back and support a perineum and catch a baby. But that's what she deserves. She deserves you to lie on your back and serve her. This idea of stirrups really was for the convenience of the practitioner.
Well, yes, and also how many studies have been done that stirrups really are not only not convenient, very painful, very
Absolutely.
damaging to your back and your
Absolutely.
spine
Well,
and
they're
your muscles,
completely unnatural.
and completely unnatural, and can be very detrimental to you and your health,
Right.
and not a really the most ideal way to have a baby. But that's something that has developed and through births and all. But I didn't have stirrups either, because I read that and said, "Oh, I don't want that either." But that's true. You know, and then there's the birthing chair now. You know, which they said is really it seems to be very natural. But you're right. You know, the idea of stirrups is just not conducive, maybe, to the most ideal way of delivering for you. And that's my feeling. And that studies have been done on that. Boy, this is a real controversial show. Because I know there are a lot of people going to say a lot of things, but what we're talking about are studies that have been done, and articles written, and a lot of time and effort into this topic.
Absolutely. I mean, the evidence is overwhelming now that the kind of midwifery I practice and the way that I was trained is the midwifery model that would really help lower the perinatal mortality morbidity rate in this country. You know, we're really not doing very well.
No.
We're 25th, which means that 24 countries lose fewer babies than do we. We're not doing well. And I think that the show also speaks to the fact that let's hear from our midwives. The fact is that I've done 3 episiotomies in 520-something babies and in 14 years with many, many, many intact perineums. That meant that the woman never had to be sutured. She had some little tear that was very negligible. Why are greater than 85% of women still having episiotomies? It is an unnecessary surgical procedure, and that's not my opinion. That's from the World Health Organization.
And just like stirrups, as you were just talking here, I mean, even now, hospitals, even here in Vermont, and I only say that because sometimes people think, well, Vermont's the last place to get this or that. I hear that all the time. We're the last place to get the best fashions or the movies or this technology. Even here in Vermont, they have the birthing chairs, and even some small hospitals, they have the birthing table. We're part of the table drops, and they are getting more and more away from that stirrup business.
Yeah,
Right.
I think that the whole thing is a call for women to truly read the evidence, read the research, and be very discerning about the fact that maybe because it's done one way in the hospital, it's not the way. Things are changing very, very quickly and very rapidly, and women really need to be their own best advocate, to really read and see what's happening, to take a global look at what's happening in maternity care, because we can see that things, for example, in Holland are done very, very different than they're done in the United States. That's the country that has the greatest proportion of home births and correspondingly has a very, very low infant mortality morbidity rate.
Do they really?
Oh, yes.
Amazing.
Yes.
Amazing. What about Canada?
Canada's very progressive, actually. They're really starting to recognize and honor their midwives. Their midwives have made great strides in their legislative efforts. More people are having home births in Canada, and the same thing is happening.
Well, the whole idea and the whole concept is the hospitals are wonderful, birthing centers are wonderful, and midwifery is wonderful too, and that you have an option and you have a different route to go, and it's okay. It's okay because it's safe, it's very normal, it's very natural, it's been done for thousands of years since time began, and it's okay, and that you, all of you who are midwives, plural, have the ability to wonderful training, professional certified training, and you bring all this equipment with you, such as oxygen tanks and whatnot. And that really there's 5%, you've had only out of 520 babies, just that 5%.
5 or 6% who go into the hospital.
Who have to really have a serious training
Yes, who are
condition,
transported.
who have to be a transport. And And that happens because nothing in life is perfect. Even if you're in a hospital, you can have complications.
And that's not a failure. That's no reflection.
No,
the
it's
fact
not reflection
is,
on the doctor, the hospital, the midwife, the mother, anybody. It happens.
Sometimes they're called failed home births, Patty, when we
Yes.
get them into the hospital. The fact is that they needed to be there, and that's fine, because the most important thing certainly is a healthy mother and baby.
Right.
I wanted to tell you that also there's a wonderful midwife in Vermont and Addison County, right here in Addison County, Carol Gibson Warnock, who was interviewed on the Oprah show and said something I had never heard,
What was
that
that?
greater than 90% of all people ever put on this planet were born at home. And I didn't know
See?
that. And when I saw her, I asked her, Carol, is it true? And she said, oh, yes.
So that's a wonderful, wonderful.
That was
Concept.
beautiful. The advent of hospital birth is new. It's new. It's
Yes.
not
When
old.
would you say the 40s, the 50s?
After World War II.
After World War II. So
After
really,
World-
really my generation.
The 40s, the 50s, right.
Yeah.
And the 40s were, once again, that was the time when we really had improved sanitation, improved nutrition, potable water, and then concurrently you had that low drop in perinatal mortality morbidity rates. And, you know, I say respectfully to the medical system, you took credit for that, and it wasn't really the link. We anthropologists, sociologists know that wasn't the link. It was just because women took better care of themselves. That's all it was.
Well, Roberta's here to tell you that it can be done. It is being done. It's okay. It's safe. You have a link with your own obstetrician. You have a link to a medical center and a hospital, I'm sure within a few miles, within a short distance of your home. So if there is a problem, you can be there in a flash, because I think probably that would be one of the biggest concerns a woman would have, or about having a baby at home, just in case something happened. And that it's okay, it's all right, and that it's certainly a much more personal experience, and certainly one that can be a very loving and gentle experience for both you and your baby, and certainly should be really evaluated more carefully. I'm one to say that. I didn't have my baby at home, but I did the next best thing. And that, to me, was extremely important. I think it's made all the difference in my daughter and I being very close. I think a lot of those factors are important in the whole emotional well-being of that baby growing into a child, into an adult. And people might think I'm crazy and all, but I do believe in that how a baby comes into the world, and those first few minutes can be real significant for the rest of their life.
I would agree. I would agree with that. I think the whole experience for that woman colors how she's going to parent. Either you give birth, or somebody births your baby. You know, there's a difference. It is a rite of passage for women. It's a transition. And sometimes a woman who previously didn't think she did much right in her life really feels an enormous power and strength from being able to give birth. And therefore, that spills over into how she parents and raises that child. It really is a beautiful thing. I'm not saying it's the cure-all, but it's a little bit, it's a little piece of it.
And a lot of little pieces make a huge, wonderful pie.
That's right. That's right.
And that's what we all are. I say this
That's right.
on many shows, and when I give lectures all over the country to women and young women, I say we all are a pie, and our lives are a pie, and each slice represents part of our life. And if you have the right amount of slices, then you make a really terrific pie.
That's right.
And if you're missing some of those slices, you're not going to have the whole pie.
Right.
And that's what we all try to strive for in life. And this is a good way to start making and building that pie and putting it together.
I think so.
I think so too. It's been just delightful to have you on the show. It flies right by.
Yeah.
An hour is
it
nothing.
was really
it's
delightful.
like sitting in someone's living room and having a little chit chat. I certainly hope this has empowered many women, dispelled a lot of questions and apprehension, because there is. And that was part of the reason I wanted to do the show. When you asked me, you know, what was the purpose, did I call you to invite you, was because I wanted to show the beautiful aspects that this profession can give to the human race. And that's what it's all about.
Thank you.
For me and for you. And I hope for you also. I'm Pati Papineau. You have any last closing words you'd like to give briefly?
Said it so well. I'd just say to just do the research, and for women to truly trust themselves and who they are, that women are so bright and so powerful.
And also for someone like, such as Roberta, who is a midwife, it happens to be in Rutland area, but they are around Vermont or wherever this show you might be seen. We are seen in different states. To look under the Midwife Association and talk with a midwife. It's an option, like visiting a birthing center. You know, explore options in life.
That's right.
Because knowledge is power.
Yes.
And that's important for all of us. I'm Pati Papineau, and you're looking right now on screen. Now you're looking at me, but you were looking at Roberta Devers, Devers Scott. Interesting name. English?
Long story.
Long story. Another show.
Short on time.
Short on time. We're winding down. And we're doing a very nice talk on motherhood and love and family and caring and peace and options, and most of all under the whole umbrella of being midwives and having that as an option for the birth of your child. I hope you enjoyed it. Keep the letters coming in, and I appreciate you watching me. And until our next show, please drive safely and be happy.